Well, welcome. We are very excited to have you all here. We were unable to meet for the past 2 years, so this feels extra special. My name is Paula Landman. I'm the nurse navigator with the melanoma program.
And I'm Trish Long, I work with surgical oncology nurse practitioner with the melanoma program.
We have some really awesome speakers today, and I'm very grateful for everybody's participation. This event is co-sponsored by the Melanoma Research Foundation. We're very grateful for their moral support, their financial support.
Hello, and welcome to the Melanoma Research Foundation's 14th Annual Patient and Caregiver Symposium series. My name is Kylie Lapira, CEO of the MRF. Thank you so much for joining us today. We hope that this event empowers you and provides you with the tools and information you need as a patient or caregiver to navigate your journey. I want to start off by thanking our generous sponsors of our National Symposia series, Alkermes, Genentech, Bristol Myers Squibb, Iovance, and Merck. And I want to also start off with just giving you a little bit of history and overview of how the MRF started and a little bit more about our mission. So the MRF was founded 26 years ago by a patient by the name of Diana Ashby, who was suffering her third recurrence with melanoma. At that time, there were very limited treatment options. And out of her frustration came the idea of bringing family and friends together to fundraise for melanoma research. Over the years, our mission has expanded as we not only fund research, but we also educate the patients, their caregivers, as well as the general community about melanoma, as well as advocating for their needs. Our footprint is a national one. While we are based in Washington, D.C., we have events all over the country. And you can get involved too, whether that be a Miles for Melanoma 5K run walk, attending one of our galas, advocating on Capitol Hill during our annual advocacy days, or attending events like today. In terms of the research arm of our mission, we are very excited to share that we have funded over $21.2 million in research grants to date. These grants are awarded through our peer-reviewed research grant program. But you can also be a part of that as well. Each year we call on patients and their loved ones to serve as advocate reviewers. And if that is something that interests you, please visit our website at melanoma.org. We also host scientific initiatives, as well as workshops in specific topics like brain metastases, ocular melanoma, or mucosal melanoma, as well as hosting our Breakthrough Consortium, which brings sites from all over the country together to work on research initiatives. In terms of our education, like today, which is a big part of our education program, we offer educational materials at no cost to the community. You can visit our website and either download the materials or we can ship them directly to you. We also host webinars and our animated melanoma patient videos, which are 2 to 3 minutes of animation that take very large, complex topics and distill them down to a lay audience. We also have a large focus on the rare subtypes, which include ocular, mucosal, and pediatric. One of our webinar series is called Ask the Expert. And we're really excited to share this with you all today and hope that you can register and view one of these during the course of the year. They will be a registration platform, but then we will also stream to our social media channels as well. They will be offered twice per month, and the topics will range from diagnosis to treatment, prevention, management of side effects, psychological needs, and more. In terms of our national advocacy program, as I mentioned, we are both on the federal and state level. We focus in a few core areas, such as research funding through the NCI, NIH, and DoD, prevention and awareness, access, and education. And lastly, we encourage you all to stay involved. You see our social media tags on the left-hand side. We encourage you to use those today as you listen to the symposium and ask questions. And also to find out more information, please visit us at melanoma.org. Thank you and enjoy today's program.
Very pleased to introduce Dr. Paul Googe. He is the director of our dermatopathology lab here at UNC and also professor in the School of Medicine. He and his team are kind of the behind the scenes, reviewing all our patient slides. They don't get much acknowledgement out there sometimes, but we would be lost without them, and they're always just a phone call away. So thank you, Dr. Googe.
Thank you, Trish and Paula. It's nice to be here and see everyone on a beautiful day. So, pathology, what's it all about in regards to melanoma? So pathology is the study of tissues that are removed from a patient. So it's either a sample that we call biopsies, or it might be a larger specimen removed at surgery. Those tissues are processed in the lab, and we look at them first under the microscope to evaluate and identify abnormalities that are present. And so melanoma is mostly a skin cancer, but can involve other organs. But it's identified, as you know, by that first biopsy, and often followed by an excision or lymph node samplings. So what we do are identify the type of melanoma, so there are many different types, and how large is it, and that goes into what you know as staging, the size and the type of tumor, and then what structures are involved by the cancer. And so that all goes into what you know as staging, or what is the current state of the tumor in a person, and that's used to plan treatment. And so the biopsy, you may remember, it's often little. It might be just a few millimeters, a fraction of an inch, and it goes in a bottle. Well, the bottles come to us, and they are processed by our technicians and by the doctors through a series of steps to change that piece of tissue into something we can look at under the microscope, so a microscopic slide. And these are just illustrations of our technicians at work and the equipment that we use to produce those microscopic slides. And this is what they look like. On the left, there's a tray. So I get a tray full of slides, and they have the patient's name and identifying numbers. And we start with our usual stain is pink and blue. We call hematoxylin and eosin, and that's the picture on the right. I'm holding up a slide for that patient, had a benign melanocytic tumor. It was not a melanoma. And so that's our assessment by looking at tissue under the microscope. It's to identify the types of tumors, whether they're benign or malignant, and we have all sorts of names and terms we use. But that leads to a report, and you may have seen some of your own reports, but they go to the doctor who submitted the specimen. And the basic pathology report for melanoma is, what part of the body, so what the skin location, and then if it is malignant, then what type of melanoma. And you may have heard some of the terms: superficial spreading, nodular, lentigo maligna. And sometimes they're actually metastases, so they're not primary, but they're still melanomas. And the primary melanomas, that's the first occurrence of the tumor. We give terms to classify how advanced that cancer is. So the anatomic level, so what compartments of the skin? Is it just on the very surface, or is it deeper in the dermis or beneath the skin and the subcutaneous fat? And then you may know that term thickness. That's an actual physical measurement from the top of the skin to the deepest cancer cell. And so these levels in thickness really define the volume of the cancer. How big is it? Because the volume of a cancer is in any organ, any cancer, that volume is what so strongly correlates with what happens to that tumor over time. And the bigger the tumor, unfortunately, often the more advanced and the more aggressive those cancers are. When they're tiny, just a millimeter or less, often they're not a problem in the long term. And then some other features that our clinicians use, mitosis, that's how many cells do we see they're actively dividing. And so if you see a lot of cells that are dividing, that suggests that it's a rapidly growing cancer. And then inflammation. If there are inflammatory cells in the cancer, we know that that's a good sign that the body has recognized the cancer and is trying to fight the cancer cells. And so that's the report that goes to the person who did the biopsy. Now this is just an example of one of the more common types of skin melanomas we call superficial spreading. And so this top pink kind of ribbon, that's the surface of the skin, the epidermis. And that's the first place where the melanoma cells start to divide and grow. And then over time, if those cancer cells have whatever it takes, they can invade the skin down into what we call the dermis, and they'll actually form small tumors in the skin. And so the early melanomas, when they're just in the epidermis, they may just be a flat brown spot. And as the volume of tumor grows and as they become invasive, then that's when you see physical thickening of the skin and what looks like a raised bump. And so often melanomas, when we first see them, they'll have both a flat part and a raised part. And that helps us recognize that something's going on there in that lesion. These are just a higher magnification on that same skin specimen. This picture on your right is the epidermis, and there's some single melanoma cells. That's what we're seeing here in groups. And you can see that there's a brown pigment. That's the melanin pigment that the tumor cells are making. It helps us recognize that they're melanocytes or melanoma cells, that ability to make melanin pigment. And then the bottom field is a picture of the melanoma cells actually in the dermis. And so these are the things that we're trained to see and identify and put in our report. This picture gives us illustration of how we do this thickness. And so the green line would actually be what we would measure from this top to the bottom. And this tumor was about 1 millimeter in thickness. So often after a biopsy or an excision, the next step, depending on that stage, so the melanomas that are 0.8 millimeters and thicker, that will often, the doctors will recommend the lymph node sampling to help identify whether the melanoma cells may have left the skin and gone to the regional lymph node. And we look at those, and I'll show you some examples. If the melanoma is to progress, it may involve more lymph nodes or other organs, and those at times for either therapy to try to remove the tumor so it won't keep growing, or to study that tumor to get more information for additional treatment, that the pathologist will be asked to look at more tumor. So this is an example where the melanoma is easy to see in a lymph node because it's making so much pigment, and these are not hard to recognize. But sometimes the tumor deposits are very small, or the melanoma cells actually stop making pigment, and they can be more difficult to pick up just in our routine stains. And this bottom left is a red stain that's identifying a protein in the melanoma cells. So it's used to help us recognize that they're actually there. And then sometimes we'll just see single cells, and they can be really tough to make sure that they are melanoma cells. And so we can use those stains again. So here's a group of tumor in a H&E, and then those same groups in a red stain. So these are stains that we use to identify that they are melanoma cells. We have other stains to evaluate properties of those cancer cells. And the ones you may be familiar with is the BRAF. And so that's a mutation in some melanomas that's thought to be the initial cause of that tumor growth. And so we have a stain for that BRAF V600E mutation. And that's what this is. So it's a cytoplasmic stain. And so when that's positive, we know that those melanoma cells have that mutation. And so we can really make a stain to any protein, but we have a limited number that we use in melanoma. Now this is a very nice illustration of PD-L1. And so in melanoma, we don't need to do the stain for a patient to qualify to receive the medication. But the research in looking at tumors is how that information came to be useful. And so this is a a melanoma. The top left is our H&E stain. The top right is a SOX10. That helps us identify that those are in fact melanoma cells. And then the bottom left is the brown stain. That's the PD-L1 protein on the surface of the melanocytes. And so many forms of cancer, and especially melanoma, the cells may make that protein. And when they do, it tells the body's lymphocytes, hey, don't bother me. But that's when we use the anti-PD-L1 medications to let the lymphocytes go ahead and react against the tumors. So I think you can see really what I do is mostly visual. I look through a microscope all day. And we do look at the specimens too, sometimes the larger specimens. But so much of it is trying to give information about a tumor that will be helpful to the physician that's taking care of you or someone you know with melanoma. And this is the same type of studies that are done in other forms of cancer too. And so about probably half or 2/3 of what I do is related to cancer. And much of that's melanoma, but we see a lot of common skin cancers, squamous cell carcinoma, basal cell carcinomas. And we see a lot of rashes. Some of those rashes are because of cancer drugs. And then we evaluate rashes for all the types of patients too. So these days, some of the information that you need to take care of a melanoma patient is not readily visible in the studies that we do. And so the main one that would be what they call molecular analysis. So they take an actual piece of the tumor and they extract the DNA, the genetic material from the tumor cells, and then do sophisticated molecular studies to identify abnormal genes. Now, the molecular tests really aren't, there are many different ones. Some of them will look for just one gene. Say you want to know if there's BRAF, they may just look for that one BRAF. Or they may do a limited panel of say 20 or 40 or 80 genes to look for the more common genes that are mutated in melanoma. But these days, the more sophisticated panels, they really look at the whole genome, or at least hundreds, if not thousands of genes, and pick out groups of ones that are abnormal. What the hope is that you find a gene like BRAF, then there's a drug that you can use specifically. So unfortunately, not everyone has genes that have a drug made for them yet. But I think as time goes on, we'll see more and more medications based on genetic abnormalities. So that's kind of in a nutshell what I do with my nut. And but I think mainly the pathologist acts as a resource of information for treating clinicians. And so whether that's information about a given biopsy or a given disease, because hopefully we will have access to more information about a patient's condition and be able to share that. And I think it's also important that all this information is living and continuously being reappraised, because a patient may live many years. And so we may need to go back in time and look at the tumor, say from 2, 4, 6, 8, 10 years ago, and see if there's information now that wasn't available then. And we know that, we may need to do that again. We sometimes need to compare patients. A given patient may have more than one cancer. And so we'll need to assess to see if we're dealing with the same cancer or multiple cancers. And so I think it's just a continuous challenge, I think, for all of us to try to have good information on a daily basis and then reappraise and start over if we need to. But we're there. You don't see us, but we're there. And we have phones, and we have email, and we're happy to answer questions from anybody at any time. We may not have an answer, but we'll try, or maybe we can point you in the right direction. So thank you.
I have a couple of questions.
Okay.
At the beginning, you talked about the Clark level,
Yes.
and it's in the report, but do we actually use it for any decision making?
Not so much now. I think the older doctors know it and appreciate it. So that was named for a pathologist named Wallace Clark, and he was very active in the 1970 through 2000, and a melanoma biologist as well as a pathologist. But he and this other guy, Breslau, so you see the Breslau thickness. Breslau was Australian, but they were looking to identify something that would give information of what a melanoma might do in a patient. And what that level and that measurement really gives you is a estimate of tumor volume. And so Clark looked at the anatomic compartment in the skin. So that 1 is the epidermis, the very surface, and then the 5 is the subcutaneous fat. And so to get from 1 to a 5, you have to have a significant volume of tumor that would probably be on the order of a Breslau 4 or 5 millimeter thickness. And so while it's not like in the American Joint Commission on Cancer staging now, it used to be, but the anatomic level, the Clark level, gives you a very, for people like me and some surgeons and clinicians, a very visual idea of what that tumor is when they say, because somebody tells me, oh, I had a Clark level 2, I know exactly what it would look like under the microscope. So you're right, it's not currently used to determine therapy, but it's still, I think, a valuable description or an adjective, a description of what is going on in that specimen.
I have another question. Occasionally, we'll get a patient who has had a recurrence decades later.
Right.
Can you actually look, if you can get the archive specimen, look at the specimen from 20 years ago and compare it to the current one and tell if it's actually metastases of the same melanoma?
You can on varying levels and maybe not always. Usually just to look, and they may look the same. And that's a pretty good evidence. You can do some simple stains to see if that tumor is staining for the same proteins that it was before. So at least it might be the same type of melanoma. And then that would imply that it is the same tumor. And then on a more sophisticated level, you could do molecular analysis to look for the same mutations in those 2 tumors. So we do that occasionally. I think most of the time you can kind of look at them and tell the way they're growing and their appearance. And then, like you said, if you can compare the 2, then you have a pretty good idea whether it's the same or not.
One more question, then I'll
Yes.
stop. But when you get a slide, do you actually look at the patient's chart first and look at photos and the history before you make any kind of analysis?
We usually do it the other way around. So we look at the slide. I was taught, because you look at the slide first, and that way you're not biased by information that you might have, like some awful looking thing or some unusual circumstances, and you read it or you see a picture and you just assume, oh, that's cancer. So I think what we do is you look at the slide first, kind of in a blind situation, and try to assess that tumor on the merits of what it looks like under the microscope. And then we go to the chart, see if we got it right. To confirm, that it's the right patient, it's the right anatomic location, and that it all makes sense. Because most of the time, 98% of the time, things are the way they seem to be. But we've all been around long enough that there are peculiarities sometimes that are the clue that something needs a little more study or investigation to be accurate. And that is something to remember. These days communication is so important between clinicians and between the patient and clinician that we understand if there's been a history of melanoma or cancer before, how long it's been there, how big it is. And so the more information usually makes for a more accurate assessment.
What about melanomas that are, I think the term is amelanoma, or
Amelanotic,
where there's not the
No.
pigment.
right.
Do the stains still work?
They do, exactly, yes. And that's, so it's interesting that the amount of pigmentation we see under the microscope doesn't correlate so much with what we see clinically. And so clinically, you know, if it's pink, there's no brown or black or blue, that's the idea that it's amelanotic. Under the microscope, we may actually see a little bit of pigment. But you're right, the stains are so invaluable because they will work. Some of them will stop working. Some are related to proteins in the pigment, and others are really related more to the cell mechanisms that make the pigment. But we have some very good tools, and so we're pretty good shape most of the time. So occasionally a cancer is so what we call poorly differentiated. It's so abnormal that it's not doing anything we recognize, and all they're really doing is making more cells. But the molecular analysis on those will usually show us mutations that we can identify with as melanoma. And that's something that happens over time too, that a patient today may have a cancer that's easily recognizable. In 5 or 10 years after time and different metastases and therapies, the cancer cells may no longer be recognizable as they were, but they'll still have that molecular signature usually.
How you doing, Dr. Googe? Kevin
Hi.
Gillespie.
Hi.
Silly question. Maybe you can
No.
expound on a little bit further. What is PDL1 and what are you using that for?
All right, it's a program death ligand 1. And so it is a protein that a cell makes and puts on its surface. Okay, and what it's saying is, I'm okay, don't kill me. And so what the body has the lymphocytes, and they go around looking for things that don't belong. And so if a lymphocyte has a PD1, and if it sees the PDL1, then the lymphocyte won't attack that tumor cell. And so it's actually a normal protein that's probably a bodily defense, because we all heard of autoimmune diseases like lupus or rheumatoid arthritis, where the body starts attacking normal tissues because it thinks that they're not normal. And so the PDL1 is a tissue's effort to say, I'm normal, you know, don't bother me. And so it may be a little bit confusing, but anyway, the drugs like pembrolizumab, the anti-PD1 or anti-PDL1, it blocks that PD1, PDL1, where the lymphocytes will go ahead and attack or try to take out things that they think are not normal. And that's what some of the side effects of those PDL1 are: joint pains, diabetes, autoimmune phenomena. And so it's, I think as time goes on, you know, the numbers of those drugs will increase, and also the side effect profile will hopefully get better. But they're miraculous when they work. And so that's what a lot of the excitement is about.
I am pleased to introduce Dr. Pearlstein. He is an assistant professor in radiation oncology here at UNC. And he's going to talk today about the advances of radiation oncology in the melanoma patient. And unlike Dr. Googe, who's a phone call away, Kevin is usually working parallel in our clinics with us. So he's usually an arm pull away that we'll grab him in and talk to him. So we do a lot of sidebars, and he's a very valuable member of our team. Thank you.
All right, well, thank you very much, Trish. And it's a pleasure to be here today. Just want to say thank you to Trish, Paula, everybody who helped organize this day. This is fantastic to see such a great turnout. It's really a pleasure to be here. So my name is Kevin Pearlstein. I'm on faculty here in the Department of Radiation Oncology. And really what I want to do today is to talk a little bit about some of the advances in my field and to tell you how they pertain to patients with melanoma. So in a nutshell, really radiation is an important treatment modality for many, many, many different cancers. And melanoma is no exception. However, the role of radiation in melanoma has really evolved over time. And that's as we've had simultaneous advances in our systemic therapies, in our surgical techniques. The role of radiation keeps getting revisited. So my goal today is really going to be to discuss a little bit about some clinical scenarios where at least we consider using radiation in treating melanoma, and to really emphasize some of the advances that we've seen over time that allow us to treat our patients more safely and effectively. So really, At its core, what radiation really is it's powerful X-rays that we deliver to a patient. Sometimes it's other kind of particles, but mostly X-rays. And these powerful X-rays are capable of destroying cancer cells. Now, at least in the United States, the vast majority of radiation treatments we deliver are given using a machine called a linear accelerator. And it's this fancy machine that I've kind of pictured over here on the right. And essentially what this machine does is it generates these powerful X-rays, and it can rotate around the patient. And these radiation beams will pass through the air, and then they'll pass through the patient, and they'll get to the cancer, and they will kill off cancer cells. But we've come a long way in terms of our radiation techniques. And radiation is nothing that is a new phenomenon. It's something that we've known about for well over a century. So essentially, X-rays, at least, were first discovered by this gentleman, William Röntgen, back at the latter half of the 19th century. And he subsequently won a Nobel Prize for this in short order, showing how important these things really are. But really what Dr. Röntgen was really interested in was he was trying to figure out, how can we use these for sort of diagnostic purposes? The usual X-rays that we sort of think about when we think about a chest X-ray or something. In fact, one of the earliest X-rays that exists is the hand of William Röntgen's wife's hand that you can see up there in the top right. That's her wedding ring there, I believe. But once again, this was for kind of diagnostic purposes. But as a credit to how important this was, within a year, people were starting to use these X-rays for therapeutic purposes, meaning to treat patients. Now, information didn't disseminate very quickly back in the day, so this is just very, very impressive that by 1896, we were treating cancer patients with radiation. Now, over the 20th century, we saw lots of incremental advances that helped us deliver these radiation treatments more safely and effectively. So we've come a long way from, let's see, do I have a little laser pointer here? Yeah, from the X-ray tubes that we were treating patients with back in the early 1900s, to the advent of these linear accelerators that I mentioned earlier in the 1950s. To what we really have today, these modern linear accelerators that are really capable of delivering very accurate radiation treatments. So the first scenario that I'll kind of talk about considering radiation in is what I call postoperative radiation. So this is nothing unique to melanoma. This is something that we do across many, many different cancers, because what radiation can be really effective at doing is getting rid of microscopic little cancer cells that can be left behind after a surgical procedure. Now, the good news is that for patients that have early melanomas, a surgeon is perfectly capable of getting rid of these, and there's really no need for radiation because they're so effective at getting rid of those microscopic cancer cells. However, as melanomas get more advanced, as they start to get into lymph nodes or as they metastasize, the ability for surgery alone to really eradicate those microscopic tumor cells is a little bit more limited. And it's those situations that we start thinking about additional treatments like radiation. So there was a pretty big study that was published, it's about a decade ago now at this point, called Trago 201, where they took individuals that had pretty aggressive melanomas that had gone to lymph nodes. And these individuals had lymph node surgeries to remove a bunch of those lymph nodes. And they were viewed at pretty high risk for the cancer coming back. And they gave half those individuals radiation, they just watched the other half. And what they found out is that the individuals that got radiation had much lower risk of recurrence compared to those that they just observed. So radiation works at eradicating those microscopic tumor cells. It's not perfect, but it does work. Now, there's been a lot of changes since this study was run. We've got all these amazing targeted drugs and immunotherapies. So I'm not saying this is standard of care, but it's certainly something that we think about doing on the clinical side when we have patients that have cancer that goes to lymph nodes. Because the downside of radiation is that as these radiation beams pass through things, they do have to pass through normal organs. And in doing so, we can cause some side effects. So as a kind of an example of this kind of idea, I've got a picture of a patient that I treated here where I wanted to treat essentially these lymph nodes under the arm. We call them axillary lymph nodes. And I've highlighted that area sort of in green over here. However, right next to that area that I want to treat, you've got your lungs, you've got your heart, you've got your thyroid gland, you've got lots of other important things there. And I know that if I give too much radiation to those organs, I will cause problems. I can cause low thyroid function, I can cause lung irritation called pneumonitis, I can cause cardiac issues, just to name a few problems. Fortunately, we've got a lot of great technologies these days that help us minimize those side effects. So in the 1990s, there was kind of a paradigm shift in our field where we started using CT scans to kind of understand a person's individual anatomy and kind of customize radiation plans using a technique called 3D conformal radiation. At its core, though, this is still a simple way of doing radiation. We still do plenty of it, but it's pretty simple. For this patient in question, what I would have done is I would have brought in a radiation beam from the front and a radiation beam from the back. And essentially these radiation beams would come together to deliver a full dose of radiation in the center of the patient. To show what that kind of radiation dose would look like in the patient, I kind of overlaid this kind of orange color wash on the bottom left there that shows the area getting the full dose of radiation. And as you can see, that certainly encompasses part of the lungs, those black things there, as well as the thyroid gland. I think it was pretty close to the heart too. Over the past decade, we've developed this radiation technique called intensity modulated radiation therapy, or IMRT. And instead of bringing in just a few radiation beams from a couple specified angles, we can bring in sometimes dozens of radiation beams coming from all around a patient. All of these radiation beams will still converge in the place that we want to treat it, but because these radiation beams are coming from so many different angles, we actually have the ability to sculpt this radiation dose much more effectively. So compare that radiation plan we just looked at to this one here, where that orange kind of color wash area demonstrating the full radiation dose really conforms to the area that I want to treat and really minimizes sending any radiation to the lung there and to the thyroid gland. So the way that I view this sort of radiation technique is we give the same amount of radiation to the cancer, but we really minimize the high doses of radiation that we're delivering to those other organs. And in doing so, that's how we kind of can minimize side effects. So to introduce you to another kind of technological advance in the world of radiation, I'm going to talk about brain metastases for a second. So unfortunately, the brain is a pretty common site of metastatic spread for melanoma. It's estimated that probably around 50% of patients that have metastatic melanoma will at least at some point in their disease course develop brain metastases. And the treatment options that we offer in that situation really depend on the clinical scenario. Sometimes we'll send patients to a neurosurgeon to resect these. Sometimes we'll use systemic therapy like targeted drugs or immunotherapies. And sometimes we'll use radiation. The historical way that we would do radiation treatments is something called whole brain radiation. And essentially what that means is exactly what it sounds like. We bring in a pair of radiation beams from either side of the patient, and we deliver these radiation beams to the entire brain. And we do so pretty slowly. We give kind of small amounts of radiation on a daily basis, Monday through Friday, for something around 2 weeks. And this radiation treatment can honestly have a fair number of side effects. Patients will get tired, they'll lose hair, they can have neurocognitive issues after we finish up treatment, meaning problems with short-term memory, problems with executive high-level cognitive tasks, dry mouth, just to name a few issues that people can get. But once again, over the past decade, we've developed improved radiation techniques that allow us to focus our radiation beams more accurately. Someone coined the term radiosurgery in the sense that we kind of think about these radiation beams being delivered with surgical precision. And there's a closely related radiation technique that you may run into at some point called SBRT, or stereotactic body radiation. Regardless of the acronyms, what these radiation treatments refer to is really focusing our radiation beams just where the cancer is, not on a bigger area. So to do this, we oftentimes will bring in hundreds of radiation beams from many, many different angles. So this kind of illustration up here demonstrates all of these, we call them little beamlets, coming in from all around a patient to all converge on that spot that we want to treat. The good news is since we're treating such a small area, we can actually give much higher doses of radiation over a shorter time period. It's not uncommon for us to be able to treat brain metastases in a single radiation treatment versus doing it over 2 weeks. And since we can give higher doses of radiation, this actually looks like it controls cancer much better too. The other good news is since we're treating such small areas, the side effects are pretty limited for most individuals. It's really uncommon to see issues like hair loss, these neurocognitive changes, dry mouth, things that we commonly see with whole brain radiation. There are some side effects that you can't see with this that are unique to it, but in general, it's much better tolerated. Now, unfortunately, not all patients are going to be candidates for radiosurgery. Sometimes we still have to do whole brain radiation for a variety of reasons, but we've also made a lot of leaps and bounds in terms of our radiation techniques for whole brain radiation. We can use that fancy radiation technique I brought up called IMRT to specifically avoid particular parts of the brain that we think are associated with high-level cognitive tasks like the hippocampus. We've got medications called like memantine that can really help mitigate some of those neurocognitive effects that we see down the road. And we also have pioneered radiation techniques here at UNC where we've avoided specific organs that are next to the brain, like your parotid glands, these saliva glands that sit right in front of your ears. And in doing so, we can really minimize the risk of dry mouth, which, although it might not sound like much, is a pretty big hit on patients' quality of life. So I've talked mostly about brain metastases in terms of these radiation techniques, but we can actually do these kind of more sophisticated radiation techniques elsewhere in the body too. And these are really good treatment options if we have a metastasis in a place that's really difficult to resect surgically, or if it's a tumor that's not responding to systemic therapy. So we can treat spots in the lung, in the liver, in the spine, elsewhere. The last thing that I'll just briefly mention is kind of what I view as sort of a future direction for radiation oncology, and that's how we can kind of combine its effects with systemic therapy and specifically with immunotherapy. So as many of you may know, immunotherapy has kind of really advanced the field of melanoma care, particularly for patients that have metastatic disease and more advanced disease. And as Dr. Googe was just mentioning, essentially what these medications really do is it helps your immune system recognize cancer cells and destroy them. It's kind of interesting the way that radiation kind of affects cancer cells too, and we think that it can work synergistically with immunotherapy. We know that radiation treatments actually cause changes within a cancer cell that we irradiate that may make it more visible to the immune system. We also know that radiation may actually be able to, we'll call it prime the immune system, in the sense that we can treat one spot of cancer in one part of the body, and it may actually make the immune system better able to detect cancer elsewhere in the body. This idea of treating a focal lesion with radiation and having an effect outside of the area that we treat with radiation is called the Fscopal Effect. I don't want to oversell it because it's actually pretty rare, but it's something that's actually being actively investigated in a lot of clinical trials to see if we can really kind of improve the synergy between radiation and immunotherapy. So I will kind of end things here. I'll just kind of emphasize that radiation therapy can be an important treatment for many patients that have melanoma. And the good news is that over the past century, we've really improved our radiation techniques to more accurately and effectively treat cancer patients. And the other thing that I just really want to emphasize that I think we should really hear today is that management of melanoma really requires a multidisciplinary team. Every patient in every clinical situation is going to be different. And it requires treatment input from your radiation oncologist, your medical oncologist, your surgeons, your surgical oncologists, dermatologists. And of course, we need the assistance from our experts like Dr. Googe, our radiologist, and many, many others to help figure out what the right treatment plan is for patients. And that's one of the special things that we do here at UNC. So that's all I've got today. I'd be happy to answer any questions if we have time, please.
I'm a little confused. You said before when you used to do the x-ray, when you only put one beam in, when it went through a part of the body, it could damage that part of the body.
Mm-hmm.
Well, how about now that you're using those multiple rays?
Yeah.
Isn't that doing the same thing?
Absolutely. So essentially what we do in our field of radiation oncology is we try to get a sense for how much radiation can a normal organ take before it actually has any kind of damage that we can see clinically. We know there are some organs that can handle a whole lot of radiation before you would ever know that there were any problems. We know there are other organs that can only handle a very little. We know that it's pretty uncommon for any organ to be able to handle a full dose of radiation by itself. But if we spread out that radiation dose over a larger area, meaning you kind of spread lower doses of radiation over a larger area, we know that we can really minimize the clinically significant side effects.
Okay, so the total, it'll be the sum.
It's really a mathematical problem. We got to get the radiation dose in there somewhere. Spreading it out is a little bit more gentle than kind of sending it all through one radiation beam. Great question.
I'm asking a question on behalf of one of our virtual viewers. Marvin would like to know if you could touch on the side effects and effectiveness of proton therapy versus IMRT.
Fantastic question. So I mentioned very, very briefly at the beginning of the talk that we deliver most radiation treatments with X-rays, but there are some particles that we also can use to treat patients with radiation. And protons are one of those particular particles that we sometimes use. Now, at least in the state of North Carolina, we don't have that radiation option here. Probably in the near future, we'll start developing facilities to do that in the state of North Carolina, but we don't have it yet. The nice thing about these proton therapies is that instead of these radiation beams, I kind of view it as just kind of like they hit something and they start degrading over time. So they'll hit something and they'll start losing energy, but they keep passing through things in order to deliver their radiation treatment, and then they slowly peter out. A proton beam, at least an individual proton particle, has a nice advantage of being able to be dialed into a specific part of your body. So in theory, what it can do is it can just kind of go through things, not deliver much radiation, and then bam, right where you have your cancer, it can deliver the full dose of radiation. It's a little bit idealized there, but that's the basic idea about what we want to do with it. So we do think there are some situations where proton beams definitely have a big benefit, where you need to kind of start and stop a radiation beam like on a dime, for instance, right in front of the spinal cord or something like that, that's pretty sensitive to radiation. We do think that there's probably a benefit for proton beam radiation if you're wanting to give more radiation dose that is safe for the spinal cord. There are other situations where people will try to make an argument that we think that it's a little bit more of an effective type of radiation, but really just because you can kind of show that you reduce a little bit of the radiation dose to some of the surrounding structures maybe it doesn't matter so much for something like the lung or a bone or something like that. So at least in the state of North Carolina, we don't have them, so we don't use them, obviously. Even at places that do have proton therapies, they kind of pick and choose the situations in which they use them. So hopefully that answers your question, Marvin. I know that you can't respond.
Good question. Sometimes we have patients with bone metastases, let's say the leg and arm, vertebrae, and we tell them, you're going to get radiation and it will make the bone stronger. So how does that actually work?
So essentially what happens is once you have cancer that gets into a bone, it slowly weakens the structure of that bone. Essentially, the cancer cells are going to degrade the normal support system that your bone has. And in doing so, you put yourself at risk for fractures and things like that. So radiation is not going to repair any of the damage that's been done necessarily, but what it can do is it can prevent things from getting worse. And essentially, when you do kill off the cancer with these radiation treatments that we deliver to the bone, your body will kind of scar things over and kind of stabilize things. I always tell patients that even if I treat your bone with radiation, it's not going to be a brand new bone all over again or anything like that. And sometimes we still prophylactically do surgeries to stabilize bones, even if we're doing radiation. But we do know at the very least we're preventing any further worsening of that.
Hi there. I have a question for you about stereotactic radiation for brain metastases versus the proton. We're hearing a lot about that now, and we can't get it in North Carolina. What's the difference in the two? Just dumb it down for me a little bit and give me exactly are the differences?
So essentially, when we do these stereotactic treatments, like I mentioned, essentially what's happening is a radiation beam is passing through normal brain. And as it passes through normal brain, it deposits low doses of radiation along the way. It kind of creates this trail of low dose radiation. Now, the nice thing about doing the stereotactic treatments is when you bring these radiation beams in from all around, that low dose trail of radiation is pretty small. It kind of gets spread out throughout the entire brain. And we like to think that low doses of radiation, like really low doses of radiation to the brain, is probably going to be minimally symptomatic. And that's honestly what we see with stereotactic treatments. Even though we know that low dose radiation was spread to the brain, patients never are the wiser for the most part. Proton beam radiation has this benefit, and this is more theoretical, that by not depositing that low dose trail of radiation as they make their way to the cancer, we would reduce that low dose spread in the brain even more. Now, there's a difference between being able to create like a pretty picture where it shows the proton beam radiation is purely just hitting the tumor and not the normal brain around it, versus whether that's a clinically meaningful thing. It's one of those things that it's going to take a lot more study to see if this is something that is going to be worth the extra expenses of proton radiation in terms of actually improving patients' quality of life.
Well, I'm just curious, this is new to me, but I'm just curious about why North Carolina doesn't have it. I mean, what is the true reason?
So I won't say it's unique to North Carolina. The closest radiation facilities to us, I guess Virginia does have one, then Georgia has one, but there are lots of states that don't have proton facilities. And the basic idea is that they are incredibly expensive to build. We're talking millions and millions of dollars to build them. And then you also have to ask the question of who are you truly benefiting with these proton treatments? We know that protons are incredibly expensive to deliver. They require not only a very expensive facility, but also a very expensive staff to maintain it. And in order to make sure that you are spending money on the right things, you have to make sure that what you're doing actually is going to help patients. There are actually a lot of downsides to proton therapy too. So we would not want to treat everybody with protons necessarily. There's some people that, we will never ask the question, is this beneficial or not? And I have no hesitation to send patients to a proton facility when I feel like we're in a situation where you absolutely need them. But in order to kind of make this make sense in terms of making sure we're helping patients, a lot of people have not started building them. There was a big interest in protons probably back in the, I'd say early 2010s, where a lot of people, private companies were building these. And what they found out was they weren't bringing enough money without treating patients that they probably shouldn't have been treating. So a lot of those closed down, scaled back, and now really the main people that are building them at this point are big academic institutions. Duke, UNC have both been talking about building them.
So often you may hear your clinician or oncologist say, we're going to talk about your case at our tumor board. Tumor board is a terrible name for our multidisciplinary conference that we as a team do twice a month, where we present challenging cases, new patients, and we powwow to come up with the best treatment. So this gentleman's going to get up the slides, and we have a panel of experts here that are going to come up and introduce themselves. Panel of experts, please come up and introduce themselves. We have Dr. Pearlstein, Dr. Soros here, Dr. Flynn, Dr. Fisher, Dr. Googe. And we are going, thank you, to present a real case study. If, starting with Will, if each of you can introduce yourselves and share your role here.
Hi, everyone. My name is Will Nabnett. I'm a clinical research coordinator here that works with this lovely group of people. I am responsible for managing a lot of the clinical trials that we run in the melanoma program here. So that's my piece. That's what I usually speak on.
Hi, my name is Morgan Gwen, and I am the clinical pharmacist for the melanoma group.
Hey everyone, my name is Jonathan. I'm one of the medical oncology fellows here, and I'll be one of the medical oncology faculty starting in the fall.
Yeah.
Alex Fisher, I'm one of the surgical oncology fellows here at UNC.
Kevin Pearlstein with the radiation oncology group. This one.
So this is an actual patient. We have changed his initials, and this patient presented back in 2016. So I'm going to share some of the background, and when we have the discussion points, we're going to do a little bit of time travel and pretend that it was today, where there may be different options or different decisions made as well. So this is a 53-year-old gentleman who presented back in March of 2016 with a left neck mass that was growing rapidly. In fact, over a course of a month, it grew to the size of a baseball. There was some delay in getting care. He finally got care at an outlying medical center in June of 2016. Finally, they were able to do what we call a fine needle aspiration, or an FNA, which is when they take a very thin needle and put it into the tumor to get some cells out. And what that showed was kind of a general malignant or cancerous epithelioid neoplasm, which is a fancy word for some kind of cancer of the skin. They then did a core biopsy, which was more favorable for a melanoma. So this was a very confusing presentation. And in fact, the patient first presented to the sarcoma oncology group here at UNC because we weren't quite clear about the diagnosis. Initially, it was said it could be a melanoma, it could be a schwannoma, it could be an epithelioid peripheral nerve tumor. So I wanted to ask Dr. Googe, why was this diagnosis so tricky?
So the identification of the type of cancer is made on the way it looks under the microscope primarily. And what we have occasionally are patients who come in with a mass like this man, and but it was presenting really like it was a lymph node that had a metastasis. And so then we look at it and we see the epithelial, they're round cells, they're round malignant cells with no other features to help us. But just that phenomenon of a mass in a node with malignant cells that you can't readily identifiable, statistically, that's most likely metastatic melanoma. And then we go to our special studies. We start with stains. And as I remember, this had a few markers that were unique to melanoma, but also shared by those other two things, which are types of nerve cancers. But again, the nerve cancers don't act like this man's tumor was acting. They don't. So the nerve cancers start in nerve, and often in patients, say, who have neurofibromatosis. So it's a matter of likeliness and appearance and presentation. And then I think we were swayed by the molecular analysis that he had some mutations that were more typical of melanoma. And so I think sometimes, you know, we're all kind of proud and we don't want to say we don't know what something is because then they won't like us. But we go up based on what is it most likely? And so all the evidence in this patient was that this was metastatic melanoma.
So I'm a little bit confused, Dr. Googe, because, this gentleman had no evidence of a skin melanoma. How did this happen?
Well, we don't really know. So there's several ideas. One is that the primary, or where the melanoma actually began, went away. We call that regression. And that's usually because of immunity. So the body recognizes that primary tumor and takes it out. But something about the metastasis escapes that immune surveillance, we call it. So the one possibility is that the primary went away and he was just left with metastasis. It's very possible that some of these actually begin in the lymph node. We know that some lymph nodes have normal melanocytes, particularly in the capsule of the lymph node. So that's a third one. And then there's a possibility that we don't really like to think about, but that the patient did have a cancer, a melanoma, primary melanoma, that they either don't remember having it because someone took it off and didn't tell them, or they don't remember, or that may have been misidentified. So a primary melanoma that was not thought to be a cancer, it was taken off, but then you come off 4, 6, 8 years later with a metastasis, and that early tumor is long forgotten, but the metastasis is back to remind us. So the short answers, we don't know, but those are the ideas.
Okay. So then once we have a diagnosis, we need to do scans and see is this anywhere else? What does it look like? So as part of his workup, he had an ultrasound, he had CT scans, he had an MRI of the brain, and then a PET scan. And surprisingly, the only site of disease was this large neck mass. Now, the mass was invading or blocking a major vessel called the internal jugular vein. And I'm going to show you a picture of this scan. It's not a great picture, but I think even the layperson can appreciate, again, left is right and right is left. So on the left side, you see this bulging mass that is very different. Dr. Fisher, I know this is not a great scan, but is this operable right now?
Yeah, so there would be two primary kind of considerations the surgeon's thinking about. One is whether this is operable or not, but also in the current era with all these other treatment modalities is whether surgery is the most appropriate treatment to start with, knowing that there are other options out there. And so this would be what we consider a locally advanced tumor, meaning that it's invading other structures. It could be vessels, nerves, muscles that are going to be important to the function of that area. And so when we see that, we certainly worry more about complications from surgery or long-term side effects related to the need to remove those structures which are invaded. And so for a case like this, we would typically not recommend surgery as a first therapy for those reasons.
Okay, thank you. So a lot of time, we say, okay, we can't do surgery. What should we do next? And a lot of time we'll say, well, let's think about some systemic treatment, maybe some immunotherapy. Well, unfortunately, this gentleman had a 20-year history of Crohn's disease, which is an autoimmune disease that affects the intestinal system. And he had several serious flare-ups during that time period, blood in the stool, that required prednisone, a lot of pain. So Dr. Sora, knowing this, what would you think about leading with some immunotherapy?
Great question. So as Dr. Fisher said, we will often recommend what we call neoadjuvant therapy, which is basically a way of trying to give therapy before surgery to shrink the cancer to make it either an easier surgery or a safer surgery to do. And as Dr. Googe and Dr. Pearlstein have talked about, a lot of what we talk about and think about in melanoma is this new exciting term of immunotherapy, where we basically are simplistically reprogramming your immune system to fight the cancer. So allowing your immune system to do the work that chemotherapy used to do. Now, unfortunately, as you can imagine, that if we're reprogramming the immune system to fight the cancer, that sometimes the immune system gets reprogrammed against the wrong thing. So that's where these kind of autoimmune toxicities and side effects come from. And what we do know is that people who have pre-existing autoimmune diseases. So if you see me in clinic, I'm always going to ask about autoimmune diseases that you or your family have, because we know that those folks are more likely to, number one, have autoimmune side effects in general, but number two, have kind of reactivation or worsening of those autoimmune side effects.
So you would not lead with immunotherapy considering this gentleman's situation?
It's a good question. So here at UNC, we have a group of folks that's called the IOG, which is called, it stands for Immuno-Oncology Group. And it's basically a group of physicians in every different specialty. So rheumatology, GI, every specialty that's kind of involved in these kind of medicines. So what I would do is I would go reach out to this person's gastroenterologist, have a discussion with them about kind of where their Crohn's disease, or was it ulcerative colitis? Where their Crohn's disease was at, and kind of, discuss with that provider as well as with the patient about the risks and benefits of using immunotherapy. So I wouldn't say no, but I would say I'd want some more information before I say yes.
Okay. And then let's pretend that this occurred today in 2022. So a couple of months ago, there was a new IV systemic treatment approved for first-line melanoma treatment. Dr. Glenn, what can you tell us about this? And would this patient be appropriate for that medicine?
Sure. So the name of this medication, I will use the brand name if that's okay. It's Opdualag. So it's actually made by the same company that made Opdivo. So you'll notice the first few letters are the same, Opdualag, which includes that lag-3 portion. And then it also has Opdivo. So this was studied against Opdivo, and it found that the people who received Opdualag, their cancer did not progress as soon as people who may have gotten the Opdivo by itself. So the only risk to that is that it can potentially increase the risk of side effects, because we're now blocking two different places in the immune system that would normally protect your healthy cells. So in that scenario, we may be a little bit more cautious because it may increase the risk of side effects as compared to just giving a one single agent immunotherapy like Opdivo.
So in this workup that we did find out that he had a BRAF mutation, but it is an uncommon mutation. You'll see it says C1782T greater than A. And I was wondering if Dr. Morgan Gwynn and Dr. Googe can comment on this less common BRAF variant, and also do any of the targeted therapies work for these less common variants?
So the most common BRAF mutations that we see in melanoma happen on the 600th codon, or the position on the BRAF gene. And so for that mutation position on the 600th, we do have drugs that can target it, and they can bind to that same spot, and they can turn that mutation off. This mutation, however, happens on the 594th position of that gene. And so the drugs can't quite get to that position. So we unfortunately would not be able to use those BRAF inhibitor drugs for this mutation.
That is very helpful. Thank you. Again, we're going to time travel and think about the clinical trials that we have to offer today. So, Will, what trials we have today, and would this gentleman qualify?
A few trials that we have today come to mind. Mainly, Dr. Sora here would help me administer them. But most of them are these immunotherapies that we were talking about. And what these clinical trials would do is help these immunotherapies work even better. But the less good part is they could also make the side effects even worse. So what I'm concerned about here would be the Crohn's disease. And I need to know a little bit more about that. Because clinical trials I have with all of these, I have hard and fast rules that I have to follow, because we are trying to learn new knowledge here, and we have to really keep consistent what we already know. And so with Crohn's disease, like this gentleman's situation, it introduces a new variable in there. So likely he would not qualify for the main clinical trials that I could see potentially benefiting him here. But again, it would just require more discussion and more work with all of this multidisciplinary team.
And Will, I know I didn't prepare you for this question, so I apologize, but phase 1 trials that are offered, are they a little more loosey-goosey with the eligibility requirements or criteria?
Sometimes they are, and I'm trying to think if we have any opening up right now, but these trials would be first in human trials. So again, I think sometimes they open up phase 1 trials for people that would like to receive immunotherapy with underlying conditions like Crohn's disease. So there's opportunity there, but I don't believe we have any of those currently.
All right, so we've talked about immunotherapy. We've talked about targeted therapy. Dr. Pearlstein, is this large mass amenable to some radiation?
Seems like we're kind of crossing off our options one at a time here. So the good news about radiation is that radiation, it can be effective in this situation. And since surgeries sounds like not an ideal option here, our systemic options are a little bit limited, I would strongly consider doing radiation here. I would make sure I have the right expectations with the patient though. We're a little bit limited in how much radiation we can safely give to patients in the head and neck region, because we know there's a lot of critical structures in there. And I know that if I push too hard with my radiation dose, I will cause serious problems and probably prevent them from getting additional treatments down the road. So my goals with radiation treatment here would probably be to shrink things down a little bit. That can be very beneficial. That could potentially allow for our surgical colleagues to operate, and could also probably improve some symptoms that I assume this patient is probably having at this point. So I think that radiation would be very appropriate in this situation. I probably would do this kind of slowly over the course of somewhere between probably 5 and 7 weeks of daily treatment. The main idea is that if we go slowly with our radiation treatments, that's a little bit better tolerated by most of the normal structures in the head and neck, as opposed to going very quickly with a treatment like SBRT or something like that. And I probably would use a radiation technique along the lines of IMRT, that kind of first radiation technique that I have talked about.
So indeed, he did receive 23 fractions or doses of radiation, and generally it's 5 days a week. That was almost about 5 weeks. I do recall that he had a ton of pain and probably some difficulty swallowing. And unfortunately, it was not a stellar response. There was only moderate shrinkage. So, I can remember one of the radiation oncologists, Dr. Chair, reaching out to us saying to Dr. Moskos, we've made some headway, but we're not overly impressed. So we then added pembrolizumab, which is also known as Keytruda, and he received 7 infusions of that. I was thinking about this case. Why do we pick pembrolizumab versus nivolumab at that time? My guess is it was a scheduling decision, because if you're remembering when this changed, it used to be that nivolumab was every 2 weeks and pembrolizumab was every 3 weeks. So we picked pembrolizumab because it was an easier schedule. Things have changed now with scheduling. That's probably the reason we picked the pembro. So what happened? We did another CT scan, and it showed some decrease, but we still have a similar mass effect, a similar effect on those structures in the area, including, again, that blockage of that major vessel. And the word adenopathy means abnormal lymph nodes, and that was really unchanged. So, Dr. Fisher, is it time for surgery yet? We really haven't seen a big improvement here.
So it is sometimes tough to tell what exactly is happening with the tumor based solely on a CAT scan, and sometimes the actual response can be more pronounced than what you're seeing on the CAT scan. The residual mass that you're seeing on the CAT scan can be inflammatory cells, it can be tumor necrosis, it might not actually all be live tumor cells, but I think the same concerns that a surgeon has initially still persist, and that's when you would come back to kind of a group meeting and discuss if there are second line options after the pembrolizumab that might result in more tumor shrinkage to further facilitate the surgery.
Okay, thank you. So we met with the patient again with Dr. Moskos, and we said, should we try ipilimumab or Yervoy? Its side effect profile is quite a bit higher than single agent pembrolizumab, and we were really, really anxious about his Crohn's flaring up. So the questions are, Dr. Sorum, Dr. Gwynn, should we try ipilimumab, and are we allowed to give a lower dose on any occasion?
Good question. So when I'm talking to a patient about kind of the risks and benefits of starting a new therapy that may have a substantial toxicity to it, I find it really helpful to go back to the clinical trial where the drug got approved from. So if you go back to, it's called Checkmate 067, which was the combination immunotherapy for melanoma, mainly in the metastatic or the unresectable setting, which this patient would apply for. You could see that in people who got double immune therapy, so in that trial, it was nivolumab, not pembrolizumab, but ipilimumab, that over 50% of patients had what we call a grade 3 or a grade 4 adverse event, meaning something that required discontinuation of the drug, potentially required steroids, sometimes even hospitalization. So a pretty serious effect. So especially in this patient who has had active Crohn's disease, I would be hesitant to do that. However, if this is our only option to try to get this patient to surgery, and the patient understands those risks, and all of our specialists are involved and on board, and most important, the patient's on board, then it is a reasonable thing to think about. Because we know that with dual immune therapy, we have better responses, meaning that the chance of the tumor shrinking is higher with 2 rather than 1 treatment.
And Dr. Gwynn, can we do a lower dose than usual?
Yeah, so with ipilimumab, there is what we call weight-based dosing. So we give a certain amount of milligrams based off of how much the patient weighs. We don't do that with the nivolumab or the pembrolizumab because the side effects don't really change based off of how many milligrams you may get. For ipilimumab, it does. So the more drug we give you, the higher the dose, the more risk of side effects. So they did a study to say, well, can we give a lower dose of the ipilimumab, giving 1 milligram per kilogram of body weight, compared to the previous dosing that was approved, which was 3 milligrams per kilogram of body weight. So trying to give a 33% of the standard dose. And is it still effective? And what they found is that, yes, it is, but it also reduced the risk of side effects. So for this patient, it would be a great option to give him the lower dose, knowing that it's probably going to be just as effective, but much lower chance of those side effects.
So we took the leap, and he had a terrible flare of his Crohn's. I remember talking to him on the phone. He was crawled up in pain, miserable, really suffering. This is a solid, macho man, motorcycle, really a tough guy, and he was truly suffering. We were able to engage him with our gastroenterologist that kind of has a subspecialty in autoimmune or immunotherapy related events. And we finally managed his Crohn's with prednisone and Entecort, which is a steroid that is localized to the intestine. He had hyperthyroidism and then hypothyroidism. And Dr. Gwynn, how often does that occur? Do you know as a side effect?
So hyperthyroidism happens pretty infrequently. It happens probably about 5% of the time. And it usually does convert then to hypothyroidism. It's kind of like the thyroid gets a little burnt out from being hyperactivated and becomes hypothyroid. And that occurs, I think, probably around 40% of the time.
Okay. Happily, thankfully, the mass continued to shrink. And we brought this patient back again to see surgical oncology. And, this patient had been hearing for a couple of years that this tumor was unresectable, that we could not do surgery, that it would be so detrimental and morbid. So it took a lot of effort on everybody's part to say, think about surgery now. And it took really a leap of faith on his part to do it. So Dr. Fisher, I know you weren't there in the operating room, but in general, what would this entail as far as surgery?
Knowing that the melanoma has spread to this one kind of dominant or large lymph node, the goal is not just to remove that one lymph node, but there's concern that lymph nodes around it could also be involved with smaller amounts of cancer. So really the goal of the surgery would be to remove all of the lymph nodes in that what we call lymph node basin, which is a collection of dozens of lymph nodes in that region of the neck. And so using kind of anatomic boundaries of the blood vessels and muscles of the neck, you would remove that entire lymph node packet. And I think in this case, the jugular vein was removed as well because it was known to be involved with tumor, which actually doesn't have any consequence to removing the jugular vein. In fact, it is taken in other situations when it's needed to reconstruct the blood vessel in other parts of the body. There's enough lateral flow within that. So
All right, so Dr. Googe, we get this pathology report. Can you translate this for us?
Yeah, so this was the main mass that was removed. And so you can see how sharply circumscribed it is, and that brown tissue, there's just a little bit of lymph node left, but all that tan material is a tumor. And then when I see that, it was very soft, and that color, it looks like that it's dead tumor. And so, but what we have to do is look at that under the microscope, and that's exactly what we see is just pink stuff. And so that's proteins and fibrin and stuff. But you can see the little round pink bodies, those are where the cells, what's left of them. So they're all dead. So that whole mass is dead. And just to compare what a normal lymph node looks like with lymphocytes. And so he had just the one dominant mass, and it was taken care of.
He remains cancer-free to this day. Well, thank you to our excellent panel. I really appreciate it. I'd like to introduce Ellen Ozier. She is a social worker with our palliative care program, which is a wonderful, unique team of caring experts here at UNC that are a key part of our oncology program.
So as Paula mentioned, I'm going to talk about palliative care as an additional layer of support for patients with melanoma and their caregivers. And my objectives are to provide an overview of palliative care, to dispel the common myth that palliative care is hospice care, because I think a lot of people think that those are one and the same. And in order to do that, I will point out some of the main differences between the two. And lastly, I want to talk about why early integration of palliative care, or why an early referral to palliative care may be beneficial for patients with melanoma and for their caregivers or family members. So I'm just curious how many people are familiar with palliative care, have had experience with it, or have heard of it. So what is palliative care? So palliative care is specialized medical care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness. And the goal is to improve the overall quality of life for both the patient and family. Palliative care is provided by a specially trained interdisciplinary team, which includes doctors, nurse practitioners, physician assistants, nurses, social workers, and chaplains who all work together with a patient's other doctors, including their oncologist, to provide an extra layer of support. And palliative care is based on the needs of a particular patient and not on the patient's prognosis. And so I'll talk about that a little bit more in a second. But it's really appropriate for patients at any age and at any stage in a serious illness. And it is often provided along with curative treatment. So I think that's something that a lot of people may not realize. And more specifically, what does a palliative care team do if you were to have a referral to palliative care or see a palliative care team in the hospital? As an interprofessional palliative care team, we try to meet a patient and family where they are. We really try to determine what the greatest need is for the patient and or their caregiver and move forward from that place. So it's very patient-centered in that way. It often includes one or all of the three different things that I've mentioned here. The first being pain and symptom management. Our palliative care physicians, nurse practitioners, physician assistants, and clinical pharmacists are experts in pain and symptom management. They work alongside oncologists to manage symptoms related to the cancer and or from the treatment that a patient is receiving for the cancer. And secondly, this is really more in my area, we provide emotional, psychosocial, and spiritual counseling and support for patients and their family members. We know when someone is diagnosed with cancer that it affects not only the patient, but also those around them, including family members and friends. So in palliative care, we really aim to support that whole system of people that may be involved in someone's life. So for example, as a palliative care social worker, I'm often involved in helping patients talk with their children or their grandchildren about a cancer diagnosis and what that may look like. Palliative care teams also acknowledge that a cancer diagnosis can impact other areas of a patient's life, including logistical, practical, and financial issues. So we try to assess what a particular patient or family's needs may be and attempt to connect them with resources that may support them going through their journey with cancer, from looking at applying for disability or other services and supports that may be helpful. And the other thing that we do that I think is really important is looking at how can we help a patient receive care that is most in alignment with what's important to them as a person. And in doing that, we really try to help patient understand their choices for medical treatment and to ensure that the medical care, again, receives their values or reflects their core values and beliefs. This often can include advanced care planning, and that is a process that supports adults at any age or stage of really any adult stage, any stage in life, and understanding and sharing their personal values, goals, and preferences regarding medical care. In palliative care, we often assist with the completion of an advanced directive. And I don't know if any of you are familiar with that or have participated in that process, but that includes appointing someone that is close to you or who knows you well to make decisions for you on your behalf if at some point you weren't able to make your own medical decisions. And so ultimately, our goal in palliative care is to ask patients questions like, what do I need to know about you as a person to take the best possible care of you? And so we try to take that. We look at the available options for cancer treatment, like we were just discussing in the last session, and we try to really help create a plan that reflects or aligns with what's most important to a patient and those people around them. So this really illustrates, I think, the multidisciplinary, interdisciplinary, and multidimensional supportive care needs that we often see when we're taking care of patients with cancer. Supportive care needs can be classified, as I mentioned, as physical, emotional, spiritual, social, informational, and they're often closely associated with each other. For example, depression or physical pain can contribute to poor appetite and decreased function, and the reverse could also be true. In addition, depression, anxiety, physical pain, worry, and uncertainty about the future can also impact a patient's decision-making, their spiritual well-being, and their relationships with others. And so I think this diagram really highlights the interconnectedness of the various needs that often come up and that we see in palliative care. And I think one of the most unique aspects of palliative care is its interdisciplinary nature of having different members of the palliative care team with expertise in really each of these areas and working together to really help inform care. And it also, I think, helps augment the ability of family caregivers to support the patient. I do a lot of caregiver support in my role as a social worker. So I think it's really important to know that palliative care is provided concurrently with cancer treatment. So that means that patients often meet with a palliative care team while they're receiving cancer treatment. And again, I think that's something that is important to take away from today. And the research indicates that early integration of or early referrals to palliative care can really improve a patient's quality of life and their journey through cancer and cancer treatment. So where do patients receive palliative care? So in the hospital, I work on our inpatient palliative care team primarily in the hospital. So when patients are admitted to the hospital, our team is often consulted to meet with patients and their families. Palliative care is provided in outpatient clinics and other specialized clinics. Here at UNC, we have an outpatient oncology palliative care clinic where the palliative care team works really closely with the primary oncology team, which would be Paula and her team for melanoma patients. And palliative care is also provided at home, whether that's through a home-based or a community-based team that actually makes visits to the home. And oftentimes those visits can be provided virtually. We're doing a lot more telehealth now, particularly since the pandemic. And palliative care is also provided at skilled nursing facilities or assisted living facilities, really wherever somebody is living that they consider to be their home. And patients receive palliative care by a referral to palliative care, and that typically will come from the oncologist or a primary care doctor. In the hospital, it's usually the team that's taking care of the patient in the hospital. So again, many people, I think, when we go and see people, believe that palliative care is hospice care. And I just want to highlight some of the key differences between palliative care and hospice. So like palliative care, hospice provides comprehensive comfort care for a patient as well as support for the family. However, once a patient opts to enroll in hospice care, attempts to cure a person's illness are stopped. So hospice is provided for a person with a terminal illness whose doctor believes that they have 6 months or less to live if the illness runs its sort of natural or predicted course. On the other hand, palliative care is often provided while a patient is still receiving treatment for an illness like cancer, and a patient can start seeing a palliative care team at the time of diagnosis. So those are some of the differences. And I think the most important message is that seeing a palliative care team does not necessarily mean that you have an illness that is not treatable or even curable, or that you are necessarily nearing the end of life. And I think that's something really important to take away. So why might a patient with melanoma benefit from a referral to palliative care? I think I've spoken to some of that already, but as you can see here, palliative care, often combined with oncology care, improves a patient's overall quality of life and decreases symptom burden or distress. In addition, patients and their caregivers who have received interdisciplinary palliative care report greater satisfaction in the overall care that they've received. Oftentimes, communication is improved. People have a better understanding of their illness and really of the options for their care. And 93% of people who receive palliative care are likely to recommend it to others. It was a positive experience. And there have been no adverse outcomes from palliative care that have been reported in any studies. So in summary, I think I wanted to just say that palliative care really aims to see the whole person beyond their illness, and that includes whoever they consider as family, whether biological or otherwise. And the goal of palliative care is to help patients and their family members or caregivers who are facing a serious illness to live the best life possible for as long as possible. And I want to close by sharing a quote from a UNC oncology patient that I had the privilege of working with when he was receiving care at UNC. I think I have found in doing this work for many years that the patients and families I've been privileged to meet and serve have really been among my greatest teachers. And this quote is from a life review interview I was able to do with a patient. It was really important to him to have an opportunity to say certain things to his wife and his 3 teenage children in case he were to get sicker. So I actually keep this quote on the wall in my office and I look at it often. And I think it's a reminder to all of us to try to focus on living fully for whatever time remains. So when I asked this patient what advice or words of guidance he wanted to pass along to his children or to others in general, he stated, create a great life. There are moments that only you get to have. There are experiences that nobody else gets to have, only you get to have. Follow your heart, do things you like to do, be open to life, be open to opportunities, be open to saying yes, to following your passion, be open to connecting with your soul and live from that place. That is what makes your life unique. Pursue what brings you joy, because what brings you joy is looking for you. So I appreciate the patient sharing that with us. Have some references here, and I'm happy to try to answer any questions that anybody may have about palliative care and what we do and how it might be helpful.
I've been waiting for you as a speaker for a long time because I've had this melanoma a long time. So it makes me sad that my girls are not here this time to hear what you're saying. They love me, but they're trying to put a hold on me on what I'm doing. So I wish if I can have the joy of doing what I want to do, I'm going to continue doing it. So thank you for this message. I will have this melanoma 30 years this November. Been stage 4 since 2008, been in the clinical trial. I'm a survivor of it, whether others are not, I'm sorry to say. But I'm glad to be here today, glad to have my UNC friends and helpers with me. And so thank you for this message. I've been waiting a long time.
I know that when seniors who are over 65 go on hospice, they kind of leave their Medicare plan and they're on the hospice program then till their death. Is palliative care the same where you leave Medicare whenever you're on palliative care?
Great question. So no, that's not the way that palliative care works. Typically, palliative care for Medicare recipients is billed as a specialty visit under Medicare Part B. There is sometimes a copay depending on your insurance plan, but most insurance plans do cover palliative care, and it is not the same as the hospice Medicare benefit, which you're right, it is an all-inclusive benefit that really focuses solely on comfort. You're welcome. So as part of our conference, we always invite several patients to share their stories. And when I contact them, I say whatever you'd like, whatever is meaningful to you. So Janice Sykes is going to speak. She was supposed to speak 2 years ago, and here we are, since we had to cancel it 2 years ago. But I know she's been an inspiration to our team as well as lots of people in her community.
I want y'all to bear with me. As a child, I stuttered. And when I get nervous, I still stutter. So if you hear me stutter, you know why. But this is a 4-year promise that I made to Paula. A bad test for me, and then COVID kind of came between me and being here. But I'm thankful to be here today. And that's the first thing I want y'all to understand. I had my first melanoma in 15, re-diagnosed in 17, and I'm still here. I'm still happy. I'm still alive. I'm 70 years old, and I'm a wife, I'm a mother, I'm a grandmother. I'm an RN, and I graduated from Carolina. And I learned a lot from Carolina, and I always swore after working here that I wouldn't come back. Well, guess where I came? So how did I get here? It's a long story. I had my first basal cell at 26 on my leg, met a nice doctor who was in Burlington. He actually taught surgery here. Dr. Patterson saw me every 6 months until he retired. Sometimes I would have 30 places frozen off me, but I never had a big issue. Upon his retirement, I saw a new doctor. And I remember after the first or second visit, I told her, I have a place on my back. I can't see it, but it stings, it burns, and it itches. She looked at it and she said, it's nothing, don't worry about it, leave it alone. That was in March of 14. I went back in June again. I said the same thing, same results. When I went back in September, she'd promised to take it off, but she was pregnant and nauseous and didn't want to get into that. So I waited till December. Right before my appointment, she went out on maternity leave. So it was March of 15 before I saw her. I took my husband with me that day, who you will find is the more gregarious of the two of us, and his checkbook. And the demand was made that we wanted that one taken off, along with a pretty little brown mole on my tummy that itched. She did, and $2,600 later, she took both of them off. And as I left that day, she said to me, you've just wasted your husband's money. That was on Wednesday. And on Tuesday before Easter, I got a call from her that both of them were melanoma. The one on my stomach was a stage 0, no issue. The one on my back was a 2B. Her famous words to me, and may have been the only thing she ever did positive. She said to me, if you want to live, you're going to go to Chapel Hill and see Dr. Alila. So I showed up. Met with him in Hillsborough. He agreed. He had gotten my stuff from the other group, and his pathologist had looked and agreed that it was a 2B. So I went into surgery 2 weeks later. After having my sentinel node mapped, the tumor was taken out, or the area was taken out. And when I say I look like I went 2 rounds with Jaws, I do. I have a huge scar on my back, but that's okay. I came out with a port, with a drain. And when I went back 2 weeks later, he said, your sentinel nodes were clear. I think we dodged the bullet. 2 years later, in April of 17, I leaned across a chair to find that I had a very sore spot behind my left breast. Now, every female in my family's had breast cancer, so this is what I thought. I had a biopsy, and I remember that day at the biopsy, the doctor said to me, "This has a blood supply, so I'm pretty sure it's a tumor." I went home that afternoon and I called Dr. Alila's office. Trish called me back and said, "I'll make you an appointment next Wednesday, and if we don't need it, we'll cancel it, but it's on the books." That Friday, I got a call from the doctor who said to me, "Your biopsy was malignant melanoma. It's metastasized." He said, "Your tumor's large. You've got 3 months at most. Go home, get your affairs in order." And I went home from work. But I called again to Dr. Alila's office, and these lovely ladies called me back, and they were like, "No, don't go there yet. Come on back. We'll see you Wednesday." The next Wednesday, I saw Trish, who set up a PET scan. The PET scan showed that I didn't have it anywhere else in my body. So back to surgery, I went again with Dr. Alila to take out all my lymph nodes and a large part of my tissue. I went back 2 weeks later. The PET scan was good. And as Trish was pulling my drain that day, my area drained all over her brand new shoes. I owe you an apology. But then whenever I went on from there, I was assigned to Dr. Moschas. I went to see him. I met with a guy from the group that was having the studies, and I was given a big pack of papers that explained my options in immunotherapy. As a nurse, it was scary because I know you're going to be putting something in my body that doesn't belong there, and I was nervous. But the group was so good with me to work with me, and the decision was made that I would go into the study of 2 drugs. The computer would pick the drug I got. I had no choice. But I had a few tests I had to do in the meantime, along with a lot of research on my part. And I prayed very hard to get one particular drug because it seemed to have less side effects. But in the meantime, I had to have an MRI. I'm claustrophobic. I can't go in a closet and shut the door. So Valium and me and a very good team of radiologists, I had the MRI. They told me to have a good July the 4th. I was going to have a port right afterwards. And I went to the beach. The day after July the 4th, I got a call from Dr. Moschas. And his first words to me was, "This changes nothing, but you have a spot on your brain." Okay, he said, "You got some options. We'll talk about them next week." When I went back, the options were to see if the Keytruda would kill the spot, to have the stereotactic, or to just go as we were. The decision was made by me because he knows I don't like to watch anything. They're my most unfavorite words, is watch it. So the stereotactic was my decision, and I met a very nice guy, Dr. Gupta, who set all this up. I met a whole group of really wonderful radiologists who planned this procedure. And as far as the procedure went, it was probably the most unprocedured procedure I've ever had. I had no side effects, except for the 80 milligrams of steroids they gave me beforehand, which jacked me up for 2 days. I had my port put in. And on August the 1st of 17, I started Keytruda. This is the drug I wanted, and that's how I got it, was by the spot on my brain. The next year went by pretty good. Every 3 months, I had CTs, MRIs. I did have side effects. I had, they were talking about the thyroid. My thyroid went up to the ceiling, and they gave me some medicine, and then it bottomed out, so I could barely walk from chair to chair. A little dry mouth, but the rash was horrible. medication, the rash went away, and I went on. I remember coming to the to this program that May, and I was still scared because I still had that 3 months in the back of my brain. And I was living, I'd made it past the 3 months and I'd made it past the 6, but when I put my Christmas stuff up that year, I remember I had labeled everything so my family would know what was in each box. I did really good after that until August the 1st when Dr. Moss said, "We're stopping your Keytruda," and I panicked because it was like having your foot on a snake. As long as I was taking it, this thing was going to stay away. But we agreed reluctantly that day. And I went on with my life. I did great until March when I went in and I had my CT of my abdomen and my duodenum was swollen. So I met another great doctor, Dr. Gangarosa, who went in, did the endoscopy, a biopsy. When it came back, they found no cancer. But down at the bottom of the little form that you get that comes in on your iPhone chart said, "Oh, well, just a side thought is they could have missed it. They could have not gone deep enough. So there's still a little uncertainty." I understood that. But we go back through the doctor line and they all decided that we would wait to see what July showed. And when I went in July of 19, it was gone. Whatever it was gone. And I've done really well since then. I've been thankful for every day. Now, has it been perfect? No. In August of last year, when I had my brain MRI with Dr. Gupta, again, at the bottom of the little report, it said the 0.5 centimeter place that's in my right parotid, which nobody had mentioned, that they had seen in 19 had grown to 0.9. And right now we are in the process of waiting to see what we're going to do with that. I have added a new doctor who is looking at that. And as a matter of fact, Wednesday, I have an MRI with Dr. Gupta. And on Friday, I have an MRI, and you remember I'm claustrophobic, right? For this area here. Nobody seems particularly worried about this area. Could be a totally different cancer. It could be nothing. But I think right now in my life, I've learned to enjoy every day. Melanoma is not who we are, it's what we have. And you can't let it lead your life. Oh, that first October, I remember crying on Paula's shoulder after Halloween because I was sitting out, giving out candy, which I love to do. And this lady comes down the street, hollering at me. "I'm so sorry you're dying," she said. "But it's okay because we're going to take real good care of your husband after you're gone." Guess she didn't know I was stubborn enough to stay here and take care of my husband myself. There are funny things like that. I have recently had the opportunity to converse with a doctor who gave me 3 months. And I've reminded him that you don't do that. Don't tell people that. No matter what you're thinking. And these lovely ladies and all the doctors I've seen have never said to me, "We're going to make you live for another 30 years. But they have said, "We're going to give you as long a time as we can give you." Do I think I'm cured? No. I'm what I called NED, no evidence of disease. And I'm extremely glad to be there. If this turns out to be something, I'll deal with it. I've learned how. I've learned that the people here at Chapel Hill will work every step of the way with you. What do you need? You need a support system. Mine was my family. This was harder on my husband and my daughter than it ever was on me. They were looking at losing me, and I, in my faith, was just looking at changing addresses. But you do have to have something that gives you courage. I don't care what that is. To me, it was my faith. I'm a stronger person today than I was 5 years ago. I'm more at peace with myself. As Billy Graham says, I know who I am and I know where I'm going. It wasn't an easy journey, and I don't wish cancer on anybody, but it's made me a better person. It's made me appreciate little things, even the birds building nests, watching the bee fly from flower to flower. I've made it my job right now to help anyone going through this journey. Paula has my phone number, and anybody is welcome to call me. I will talk to any of you. So with my husband. Take time to enjoy what life has to offer. And again, melanoma is what you've been diagnosed with. It's not who you are.
Thank you, Janice. We'll be thinking about you this week. Hope the claustrophobia isn't too bad too. Next, I want to introduce Dr. Michael Myers. He is a professor of surgery with us in the Division of Surgical Oncology, and he's going to be talking about the evolution of surgery in the care of advanced melanoma. I think if I did my math right, you're going into your 20th year that I've had the honor and privilege to work side by side with him. So not only has he done his research, he's lived through all the changes that has come in the care of melanoma through surgery.
Thanks, Trish. I appreciate it. Yes, 20 years here in Chapel Hill. And certainly when I got here, not only was I a few years younger, I was a few pounds lighter, and I had a lot less gray hair. So I thought I'd just talk a little bit about some of the changes that have been perhaps more recent changes in how we think about caring for melanoma from a surgical perspective. These are kind of summary points, and I'll kind of show this at the end and emphasize a couple of things. But really the biggest trend is toward less invasive treatment. We are doing less surgically with the same outcomes, and there's a variety of reasons for that. Partly because we understand the disease better. We have had the opportunity to study it more, and partly because our treatment has improved. Other treatments have improved, and you heard a little bit about some of things like immunotherapy, and I'll mention that. And we're starting to define the role of melanoma in the immunotherapy era. And this is moving quickly. More limited surgery for potentially resectable disease, so things we can take out. We are oftentimes able to do that with less surgery because the treatments are better. And perhaps even an expanded role for surgery for more advanced disease, things that we didn't used to think were treatable surgically. Now we're coming back around to some of those thoughts. And then finally, a little bit of a realignment of thought about stage 4 melanoma. If it has spread somewhere else, other than just the area, other than just lymph nodes, how are we thinking about the surgical management of patients? And that's still a area that's in progress, and that story remains to be told completely. But I thought I'd start by talking just a little bit about sentinel lymph node biopsy. Certainly some of you are familiar with this. This is somewhat minimally invasive way of identifying whether melanoma might have spread to a lymph node. And it's a procedure we use quite commonly in patients who don't have any clinically detectable evidence of melanoma spreading. You come see us with a newly diagnosed melanoma, and much of the time we will recommend a sentinel lymph node biopsy or sentinel lymph node procedure. There's a relatively low chance of side effects, certainly compared to what we used to do, which was take out all the lymph nodes in the region, and the recovery is relatively rapid. And it's a low chance of side effects. Unfortunately, it's not zero, and some people do have some complications or side effects with this, but in general, the procedure is pretty straightforward. This will be familiar to some of you. We have, I think you can see you can't see the cursor. On the slide left, you have a syringe injecting some dye on a melanoma on the arm. And that dye travels through lymph channels to lymph nodes. Lymph channels are little teeny, almost blood vessel-like channels that connect lymph nodes to each other, and they travel under the skin, kind of just under the skin layer. And this is how melanoma travels. The lymph nodes are part of your body system to get rid of things that aren't supposed to be there. lots of reasons lymph nodes will be enlarged. Infection's one of them. If you get a sore throat, you'll get a swollen lymph node in your neck quite commonly. Well, much of the time your body identifies cancer as not supposed to be there, and it's trying to get rid of it. So your body will try and take some of these cancer cells away. It'll track them through lymph nodes, and they get hung up in those lymph nodes sometimes. A lymph node is a big filter. So we inject some dye, and in the middle pane there, you see us using a little handheld probe. And that's what we use in the operating room. If you've had this procedure done, you know that we take pictures with a larger camera in the X-ray department before surgery, and that marks the place for us. It doesn't mean melanoma has spread. It just tells us where it's most likely to have spread. And then we come to the operating room, we make an incision, and these are relatively small incisions, usually 1.5 inches or in that neighborhood or smaller. And we use a handheld probe to take those out. So in actual practice, this is a little bit what it looks like. On the upper left of the screen, you'll see that label. This is a recent patient of mine, injection site. That was on the upper arm. So we inject a dye that we can see radiographically, and then you can see the sentinel lymph node with a marker on it, and that's under the left arm. Common place for something in the extremity to go to. Now, we've been doing sentinel lymph node procedures and sentinel lymph node biopsies for a long time. 25 years in earnest, and prior to that, we certainly had started, although it hadn't been widely disseminated. Prior to sentinel lymph node biopsies, we do lymph node dissections. So screen left is under the arm. And you, I think, can see or appreciate an incision kind of extending from the muscle kind of on your chest to the backside. And these are incisions that usually are 4 or 5 inches long. And you can see the concavity there. That's a lymph node dissection under the arm. This is what we used to do for the majority of melanomas, as opposed to a sentinel lymph node biopsy. And on the screen right, this is in the groin. So this is the left leg. This is the top outer area incision here. And we take the lymph nodes out roughly where that 8 pin is. You end up with a drainage tube after that. And this is certainly the potential for a lot more long-term side effects or complications associated with this. So 25 years ago, 30 years ago, we figured out we could do the same, gather the same information with a much smaller procedure. But what came after that? Well, for many, many years, if you had a lymph node that had melanoma in it, and of the patients who have a sentinel lymph node biopsy, 15 to 20% will have melanoma identified in the lymph node. Our subsequent recommendation was this: you've got melanoma in this lymph node. We need to do another operation, a lymph node dissection. We need to take more lymph nodes out. We need to find out if there's more melanoma in those other lymph nodes. And so there was a lot of conversation and discussion about the importance or utility of that. And that is the biggest change in the last 10 years, is the change in management of a positive sentinel lymph node. A patient who has a sentinel lymph node biopsy has melanoma in it. You're one of the 20%. Now what do? Well, forever, we would do just that, a lymph node dissection, as I mentioned. And now our current recommendation is for the majority of patients, not everybody, and there's some subtleties that go into that, it's observation. That information is thought of more as prognostic as opposed to therapeutic. The information we get from a sentinel lymph node biopsy informs our thought process about any other treatment, how we're going to watch things. Do you have scans or not? All of that is important information that helps us think about that. But we don't subject everybody to a completion lymph node dissection anymore. A very much smaller number of patients may benefit from that. And the data behind that was a study that took a number of years to complete, was published in the New England Journal of Medicine in 2017. And for those who don't follow medical literature, this is the biggest and most important publication journal that we have in medicine. The most important things get published here. So that gives you an idea how important this contribution was. And this study took people with a positive sentinel lymph node and put them in one of two categories: completion lymph node dissection immediately, or standard, or observation. And observation isn't just call us if you need us. Some of you, if you've followed that paradigm, and that might be you, know that that's exams pretty regularly. It's scans, it's things like ultrasound tests. And if you look at the ultimate outcome, how long do you live after that? Those curves are survival curves. How long do you live after these procedures? Observation in red, lymph node dissection in blue, and they are identical. And so this was the information we needed to know that it was safe to do less. Can we do less surgery and have the same outcomes? And this is the biggest change in the last decade. And this is the consequences of some of the lymph node dissections. Obviously, these are dramatic pictures, okay? But this is lymphedema. And lymphedema is essentially all those lymph channels that go to lymph nodes in a certain area get backed up, they get congested. They don't find another pathway. And you get a swollen extremity. Usually it's arm or leg. The leg is much more significant and much more likely. And, and this can be a really challenging management problem. If you develop lymphedema, you end up having other types of therapy or other types of treatment to manage this. You may wear a stocking on your arm or your leg to manage this. And so the consequences can be significant. And so we are able to accomplish the same goal with less side effects, less complications. And that's a bit of a theme. So I want to shift gears a little bit and talk about changes in the management of recurrent melanoma. You had a melanoma treated, and now you've got something that has come back. And that falls in two flavors. One is melanoma that comes back in the neighborhood, either in a different lymph node or in the region. You might have a lump in the area. And that's another form of melanoma coming back in lymph channels as opposed to in a lymph node. And then you might have melanoma that comes back elsewhere in your body. And I'm going to spend just a moment on that. And so if you had something that came back in a lymph node, you came back 2 years after your initial melanoma treatment, and now you've got a swollen lump. Okay? Our historical treatment would be to take it out. We would do that lymph node dissection. We would take all the lymph nodes out in that neighborhood. And then more recently, we'll treat you. We'll treat you with immunotherapy or targeted therapy in some fashion. And the evolution or the change here is that now you come back with that lymph node, we're going to have you see the whole team to start with. Yes, we'll have scans, we'll evaluate what's going on. But if you just have that swollen lymph node, we're much more likely to treat you with something like immunotherapy or targeted treatment to start with. And there's, again, a lot of things that go into making those decisions, things that Dr. Googe talked about. How did those things look under a microscope? That helps inform all of these things. And then after immunotherapy, we might remove just that lymph node as opposed to taking all those lymph nodes out. Or we might just observe that, depends. And so let me show you just one example. This was a patient of mine a couple of years ago who had this exact story. So this is a PET scan. Some of you may have a PET scan. The dye we give you for a PET scan is basically a form of sugar. Things that are growing more quickly take up the sugar faster. So if we do a scan of your body, things like your brain, your heart, those are using a lot of sugar all the time because they're always working. And so you'll see those show up on scans. Things like cancer growing more quickly than the tissue around it will take up more of that sugar. And that's what you're seeing. Now the big area in the middle, that's the bladder, the urinary bladder. When your body gets rid of that dye, it does so in the urine. So that always shows up. But the area to the right, that's a lymph node. And you get some sense of that. It's not tiny, probably an inch or so. Most lymph nodes are 5, 6, 7 millimeters. So a third of an inch, quarter of an inch. So this is a swollen lymph node, and we proved that with a biopsy. We put a needle in that lymph node and found that it was indeed melanoma. Well, we treated this patient with immunotherapy, and this is what it looked like afterward. This is a CAT scan, so it's a little different. You see this little small gray dot here, significantly smaller. So historically, we would have taken all those lymph nodes out. But now we're gaining confidence that A, treatments are much more effective, and B, we don't necessarily have to be super aggressive surgically because of that. So we just take that out, and that's it. Much less invasive surgery. And excuse me. And in this particular circumstance, there was no residual melanoma in that small lymph node. And so it leads us to even more extrapolations where maybe we don't need to do an operation at all. We're still learning. This is another recurrence. I mentioned these recurrences in the neighborhood. We call those in-transit recurrences. These are in lymph channels that are not where lymph nodes live. Lymph nodes live in places like under your arms, in the groin, behind the knee. This is on the back of the calf. So this is the right and left leg, and you can certainly see the difference. And you see that large area there that's probably about 3 inches, pretty sizable. And this is a patient who got treated with immunotherapy, and it basically all went away. All we've done so far is one little biopsy, and that's it, because they responded so dramatically well to immunotherapy. So now we are in an era where the role of surgery is evolving, and we're trying to individualize that based on an individual patient. If you don't have as strong of a response to treatment with targeted medications or immunotherapy, there's a role for surgery that may be more extensive. But if you respond dramatically, we are less aggressive and less invasive. And so this is, again, the same idea. We used to remove these surgically quite commonly and then treat you. Now we've flipped the script, and we might do a smaller procedure or observation in that circumstance. So finally, let me just show a picture of somebody who unfortunately had a more extensive recurrence of melanoma. So on the right is a picture of the liver. I've circled kind of a area you'll see within that circle that looks a little more gray, a little different appearance than the rest of that kind of gray and white liver. And that's a spot in the liver that had metastasized there. On the left, I've circled a couple of lymph nodes that were enlarged. And so this is a patient who had a recurrence in more than one location. And no question that in that patient, historically, and that there was only these two, historically, we probably would have done an operation to take all of that out, even though the chance of something showing up subsequently was somewhat high. We didn't have particularly good treatment, and our treatment options were somewhat limited. We evolved to treating that patient with immunotherapy or targeted therapy, and that evolution was nearly a 180-degree turn, to the point where it's less likely that we would recommend surgery at all, depending on response to things. Excuse me. And so we went from surgery to surgery plus immunotherapy, again to immunotherapy plus surgery or not, or maybe just immunotherapy alone. And that's kind of the evolution we're in right now. Now, I don't know that everything old is new again, but many things are. And so that's the part where we're trying to work our way through. So this is where I left you, where this patient may be treated with immunotherapy. Now, do we do an operation? That's the question. And when do we do that? That's the question. And we're still working those things out. So I'm going to go back to this patient. They were on treatment. They were doing well, tolerating treatment well. The liver was stable, but the lymph nodes started getting bigger. So there was a role for surgery. We took those lymph nodes out and continued the same medications since everything else looked stable. And so that's the part where we're still trying to work our way through. How do we sequence some of these things? How do we make those decisions? And it's becoming much more individualized for any individual patient. So in conclusion, it's trend toward less invasive treatment. As I said, less surgery in general, as our understanding and treatment have improved. We're starting to define the role of surgery in this immunotherapy era, hopefully more limited, but still trying to figure out how surgery plays a role in some of these more advanced patients. And it very much is becoming a paradigm shift from, if we can't take it all out, there's no point in doing an operation, to it doesn't matter what combination of treatments, as long as we can chase everything away. That might be medical treatment with immunotherapy or targeted therapy. It might be radiation, it might be surgery. And it depends on where it is, what it is, and we mix and match those treatments. And so future directions really are around individualized treatment and kind of this concept of precision oncology. And I think the next talk, if I'm not mistaken, is kind of molecular tumor board. How to identify individual targets for individual patients and then turn that into treatment. As a whole, I think the theme you've heard is A, we work together a whole bunch. B, we're becoming much more individualized in treatment, at least for advanced melanomas. Now, we still don't have a, this is your tumor, this is your treatment plan. I don't know that we're going to get there, but we're going to get a lot closer over the next decade or so. Thank you. Be happy to answer any questions.
What was the theory behind if you had a cancerous lymph node, you had to take out the whole family of lymph nodes?
Sure, great question. So historically, in that way of doing things, we know that 20 to 25% of patients in whom we went on to take the rest of the lymph nodes out, it was right around 20%, we would find melanoma in additional lymph nodes. So if you have a sentinel lymph node that has melanoma in it, there's a chance of having some melanoma in another lymph node. And again, it's right around 20%. Why is that? Does that not impact ultimately the outcomes of survival? Well, it's a modest number of patients of the whole. And that's part of our observation. We know that if we observe everybody, there definitely is a chance of something coming back right where that original lymph node was. But if it's 15% or 20% over time, and then we do something about it, we treat you with other therapies, including surgery, we have certainly spared the majority of patients the side effects of a more extensive surgery. And so that's the idea and rationale. And as I said, not everybody would we recommend observation for. There are some subtleties that go into that as far as how we interpret some of that information and the information that Dr. Googe and his team gives us as to how we might recommend some of those things.
Would some of that be the size or the depth of the original tumor?
So great question.
Going to the
Yeah, so there's no question that that Breslow depth that Dr. Googe talked about is associated with an increasing chance of having a sentinel lymph node that has melanoma. And so as the tumor gets deeper, the chance of having a lymph node goes up. As far as our recommendations for additional treatment, if you have a sentinel lymph node that has cancer cells in it, it has a lot to do with how much melanoma is in that sentinel lymph node. Is it just a very small amount? That's the group, and it's about 70% of patients who have a really small amount in a sentinel lymph node. That's the group who is much less likely to have additional lymph nodes. So you're correct. The volume of or size of melanoma in that sentinel lymph node has a lot to do with our recommendations and has a lot to do with the chance of finding additional lymph nodes that have melanoma. Yeah, it's a great question. And so that's part of why we're watching things pretty darn closely. And that, as I said, that includes ultrasound tests. We use ultrasound in that circumstance complementary to scans like PET scans and CAT scans. Ultrasound will find things before they even start to get bigger. They'll show us that the lymph node now looks abnormal. Kind of the character of that lymph node looks abnormal, and that's actionable in our minds. And so it's really unlikely that a melanoma in a lymph node is going to go from this to this in a flash. That is super duper unlikely. And in the big study that's done, that it just didn't happen. Yeah, usually within a couple of months, and sometimes even a couple of treatments. In the best of circumstances, the responses can be very dramatic. Yes, sir. Yes, sir.
Can you talk for a second about the types of melanoma cells in the lymph nodes and how that relates to the future, to the spreading and so forth?
Yeah, so there are some different types of melanoma. In the lymph node, really the melanoma itself is not much different once it gets to a lymph node from a behavioral perspective. Melanoma skin, there are some variants and types that behave differently. But in a lymph node, they primarily behave quite similarly. Now, What really matters when we biopsy things and biopsy that melanoma on the skin is what kind of markers does that make? And those are some of the things that Dr. Googe talked about, and a couple of you asked questions about. PD-L1, BRAF, some of these other markers of biology that help us think about how this might behave, how aggressive it is or non-aggressive it is. Those are the characteristics primarily that we're looking at, and truly still trying to figure out how best to manage some of those things in the context of additional surgery.
So next, I have Jamie Richardson is going to speak with us. And you heard me mention Tumor Board before. She is part of the exquisitely smart molecular tumor board. They speak a different language, but we often consult with them when we have a challenging patient that we want their input on what are these mutations and what can we do about them. So come on up. We're very honored to have her here today.
For the record, I don't think I'm one of the exquisitely smart ones, but I will do my best to translate for you guys. So thanks, Paul and Trish, for inviting me. I'm very happy to be here. So I'm going to be talking about precision oncology and the role of the molecular tumor board. And I'm going to start out with a little bit of background on both precision medicine and precision oncology. So precision medicine, we've really come a long way in fighting common diseases. So historically, the approach to treating the disease was based on finding the most effective treatment for the average person. And this was especially true in cancer. But what we learned with is that once we learned about the influence of individual factors, both on the disease process as well as each person's response to treatment, the more we realize that this one-size-fits-all approach doesn't really work very well. And what precision medicine does is it takes into account these differences in patients' genes, environments, and lifestyles. And this really came to the forefront in 2015 with the Precision Medicine Initiative. And this was $215 million in government funding, 70 million of which was allocated to the National Cancer Institute, specifically to advance the field of precision oncology. So what is precision oncology? This is a very, very high level overview, but traditionally treatment was based upon where in the body the cancer started. So if you had lung cancer, you got this treatment. If you had colon cancer, you got this treatment. Precision oncology enables us to detect unique changes in patients' cancer and target those with specific treatments. And over the past 2 decades, the use of targeted therapies has increased exponentially. And with regard to immunotherapy, which many of you may be familiar with, we are still learning why some people's cancer responds better or longer than others. So precision oncology starts with DNA, and this is a little bit of a refresher slide for those of you who might not have thought about it in a while. So DNA is carried within each cell of your body, and it contains all of your genetic information. It's made up of 4 building blocks called nucleotides, and those are adenine, thymine, guanine, and cytosine. And the sequence of these 4 letters creates gene sentences, if you will, and a story that instructs cells. So small changes in the order of the letters can change the meaning of the sentences. And these changes result in gene variants, for example, a gene mutation. And thanks to COVID-19, the terms variant and mutation have pretty much become part of our everyday vocabulary. So if you think back to the Delta variant, the Omicron variant, scientists talking about how many more mutations Omicron has than Delta, that's the same exact concept we're talking about here. So there are 2 sources of DNA that we look at in precision oncology. The first concept that's important to understand is that tumors have their own unique DNA. So if we find genetic variants within tumor cells only, those are called somatic variants. Some are known to cause cancer to grow, and by identifying them, we may be able to offer more specific or targeted therapy. Then there's the normal DNA, or the DNA that you were born with. Genetic variants found in these normal non-tumor cells are called germline variants. Some can predispose individuals to developing certain cancers, and sometimes we can also target cancer-causing genes with specific treatments. This is a picture for you visual learners out there. So on the left-hand side, we have an example of a somatic mutation, for example, a mutation in breast cancer tumor only. And on the right-hand side is germline mutation, which is present in germ cells, which are agar sperm. These can be inherited and can potentially cause a family cancer syndrome. Now, how do we test this DNA? So when we're testing tumor DNA, it's called a few different terms, which can be a little bit confusing, but they all basically mean the same thing. So you might hear molecular profiling, tumor genetic testing, or next generation sequencing. And there's a specialized lab that reads the DNA letter by letter to look for gene variants. This test is most often ordered by an oncologist, and it's used to direct cancer treatment at diagnosis for some cancer, when a treatment stops working, if cancer is worsening, or for suspected drug resistance. But not all variants identified can be targeted with a treatment because we're still learning about them. When we test normal DNA, which is called regular genetic testing or germline testing, this is where a sample of blood or saliva is taken and the DNA is read letter by letter in those cells. It is used to identify gene variants which may potentially cause cancer, but it is not indicated for all people with a cancer diagnosis. Actually, most cancer is not caused by an inherited genetic mutation. This test is typically ordered by a genetic counselor or a doctor who specializes in cancer genetics, and not all variants found will have a role in the development of cancer. So moving on to targeted therapy, which you've heard about today already, and this is really the crux of precision oncology. So these are treatments that interfere with specific cellular processes used by cancer to grow and spread. Some examples from melanoma are vemurafenib, encorafenib, and dabrafenib for certain patients with a BRAF gene mutation. What this also means is that patients with different types of cancer can sometimes receive the same treatment. For example, a liver cancer patient and a kidney cancer patient might get the same drug if their tumors have the same genetic variant. And then for some genetic variants in cancer types, targeted treatments may only be available on research studies or clinical trials. The last thing I want to touch on about precision oncology is that the pace of new information and treatment options is incredibly fast. So before 2003, we did have some targeted therapies in cancer, but that year was the completion of the Human Genome Project, where scientists read human DNA letter by letter, about 3 billion letters. They read 99% of it. And once they had that reference, that really gave them a better understanding of how variants can lead to diseases, including cancer. And to put this a little bit more in perspective, there is a database that is widely used in precision oncology, which catalogs or lists all of those somatic mutations that we find in tumors. So in 2004, there were about 10,600 mutations in that database. And as of 2019, there were nearly 6 million. Same with the pace of new therapies. So this is the cover of Time magazine from 2001. And this is a picture of Gleevec or imatinib, a drug which is used to treat chronic myeloid leukemia. And this is one of the earliest times that the mainstream media really grasped this concept of targeted therapy. And they refer to it here as a magic bullet. So if we fast forward a couple of decades, targeted therapies have over 150 FDA-approved indications across various cancer types. We don't have 150 separate drugs. We have about half of that. But as I mentioned, the same drug can work for multiple different types of cancer if those patients share genetic variants. So because of the sheer amount of information and data coming through, some cancer centers across the country implemented specialized tumor boards specifically to look at this genetic information, and that's where the UNC Molecular Tumor Board comes into play. So the UNC MTB serves as a forum to evaluate tumor genetic testing results for oncology patients. We review results for solid tumors, for example, melanoma, lung cancer, breast cancer. We also look at rare cancers. It is multidisciplinary, meaning we have representatives from several specialties, including cancer genetics, medical oncology, pathology, pharmacy, and nursing. And our main goal is to work closely with oncology care teams in the interpretation of identified genetic variants to help guide an individual patient's care. I thought the best way to illustrate this was to give you a case study, and sample case study. I want to preface this by saying this is a completely fictitious person. They don't exist, but I wanted to give you a little bit of flavor of the kinds of questions that we can help answer. So we have a 63-year-old female who found a concerning skin lesion on the back of her leg in 2021. Biopsy confirmed melanoma, and unfortunately, the CT scan revealed that disease had spread to one of her lungs. She did have tumor genetic testing, and there was a BRAF gene mutation found, as well as several other mutations. Now, the BRAF mutation found in her tumor is different than the BRAF mutations, which have FDA-approved treatments, which you guys kind of touched on earlier in the tumor board. So if you look at this blue bar, this is a cartoon of the BRAF gene. So if you look to the right where the black X is in the 600th position of the BRAF gene, this is where a couple of more common mutations exist, BRAF V600E and BRAF V600K. So those areas have FDA-approved treatments. This person's mutation is a little bit to the left where the red X is, which is closer to the 400th position. And what we know from past experience is based on, even if two patients have the same mutation, the same gene, where the mutation lies within that gene can affect how they respond to treatment. And I think Morgan said it very well earlier, that targeted therapies is kind of like a lock into a key. So the drugs that we have can reach that position on the gene, but not necessarily closer to the 400th position. So this patient went ahead and started on immunotherapy. And then her physician reached out to the MTB to inquire about this uncommon BRAF mutation. Is it a potential treatment option down the road? And what are the significance of other findings on the report? So a little bit of family cancer history background. She had kidney cancer in her father, melanoma in one of her two sisters and one brother, and an unknown cancer in her paternal grandmother. So the first step in the MTB process is case preparation. And this is where the team reviews test results gene by gene. We look at prior treatment, response to treatment, family history. The team examines the most current scientific literature. So specifically how the identified variant affects the growth and spread of cancer. We look at data from research studies on that specific variant to see if there's been any treatment response. And then we assess the potential use and risk benefits of the targeted treatment in the given cancer type. We do identify potential treatment options, including clinical trials as applicable, and not every report with variants has something that we can target. As I mentioned earlier, we're still learning about some of them. So the average for this portion of the process is about 2 to 4.5 hours per case. Then we come together to discuss the case. So we present our findings and treatment recommendations as applicable for consideration with the oncology team. We can now also provide this service electronically as a written consult. And we do sometimes make additional recommendations for testing or referrals. And the average for this portion is about 20 to 30 minutes of discussion per case. Now for our fictitious patient, these are our recommendations. So we identified one potential off-label treatment option if the patient's cancer worsens and there are no additional on-label or FDA-approved treatment options. We provided information for 2 locally recruiting clinical trials for patients who have uncommon BRAF mutations. So both of these clinical trials were testing targeted therapies with the goal of identifying additional treatments for patients with tumors carrying these mutations. And we do look at other institutions for clinical trials. It's not just unique to UNC. So if somebody is willing to travel to Memorial Sloan Kettering or MD Anderson, we will look all around the country for a clinical trial. It's just up to the patient, but we typically look within 300 miles of UNC. And then due to this patient's family cancer history, as well as some additional findings on the tumor genetic testing report, we did recommend a referral to the Cancer Genetics Clinic for genetic counseling and testing. So in conclusion, precision oncology has significantly increased the amount of available treatment options for cancer. The UNC MTB assists oncology care teams with analyzing genetic testing results to help formulate individualized treatment plans. New information comes at lightning speed, and we continue to learn about cancer-causing genes, genetic variants, and the best way to target them. And then ongoing research, including clinical trials, is key to the advancement of cancer treatment. And with that, I will leave you with a picture of the UNC Molecular Tumor Board, all the team members. This is actually taken a couple months ago. It was the first time we've all been together since the start of the pandemic. So now you guys have like the brains behind the tumor board there for you. So thank you, and I'll try to answer any questions.
Initially, I had BRAF negative on the biopsy, but then the oncologist said he had to send it away for more specific mutations or whatever. So when the results come back, will your team look at that? Or is it up to the oncologist to decide that?
It depends, yeah. So Dr. Googe mentioned this morning that they can do like a singular test for a BRAF V600E mutation. And sometimes, and Dr. Calicio, correct me if I'm wrong, if one of the common mutations that they test for right up front with a melanoma diagnosis are not found, then yes, this can be sent out for genetic testing, tumor genetic testing, exactly. And then we can see if there's any other mutations. And the panels that we send out to, one has about 400 genes, another one has close to 700. So it looks at a lot of stuff. And so there could potentially be some other mutation there that's they call it a driver of the cancer. But not all those drivers have targeted treatments yet. So we're it's a process where we're learning with all of you as patients and the oncology teams.
So the oncologist will then decide what immunotherapy or whatever.
Possibly, or consult with us and say, hey, there's a couple of mutations here that aren't very common and they don't have FDA approved treatment options. What do you guys think of them? And sometimes in the literature, there's a lot of information about a given mutation and it's been tried with different drugs. And sometimes we call them preclinical studies where it's just in animals. So sometimes we don't have a recommendation. Yeah, that's where all clinical trials start in animals and then first in human. So sometimes, and we won't recommend a treatment usually based on that, but we will provide that information to the referring doctor and say, hey, all we were able to find is currently in animal studies. There's clinical trials ongoing. So maybe a clinical trial is an option, or we wait for more data to come out.
Thank you.
Yeah, thank you.
I guess this would be more along the germ line, but is there a relationship between melanoma and the CHEK2 gene?
So I am not a genetic counselor or a geneticist, so forgive me. I know there's a couple of genetic mutations that are associated with melanoma familial cancer syndromes. I'm not familiar with CHEK2 being one of them, if someone else in the audience knows that. But what we do is when we look at a report, this is hard to explain, but we get a list of mutations. Next to each mutation, if there are any, is a percentage. So if it's a low percentage, maybe 1%, 2% of this mutation in the tumor, we figure it might be unique just to the tumor. If we see a mutation that has between like 50% to 100%, we get suspicious that that's in more cells than just the tumor. And that's when we might reach out and say, hey, we think you should go for genetic counseling and testing. And that also kind of goes hand in hand with a strong family cancer history. Like this patient had quite a bit of melanoma. We put kidney cancer in there because there are a couple familial syndromes that result in like kidney cancer and melanoma in families.
Thank you, Trish and Paula, for inviting me. Thank you all for being here. Thank you, Ms. Sykes, for sharing your story, right? It kind of reminds me, I often tell my patients that sometimes I learn more from them and I get more from them than I give them. Don't ask me for refunds. I don't think UNC will allow me to do that, but thank you for that. It's always good to have that perspective. So essentially I'm a general dermatologist, right? So our role as general dermatologists is to try to diagnose, also to essentially sometimes we even treat early melanomas, right? We also diagnose other types of skin cancers more frequently. So I thought I'd give you kind of a little bit of a background, but really this is about you. So if you have any questions, please ask me. Just as everyone has said, right? This is, I will in earnest answer every question. One time a patient asked me, she said, is wearing turmeric a good sunscreen? So maybe like 10 years ago, I said, that's ridiculous. So I actually went and I read about it and I wrote her back and I said, no, I can tell you it's not, right? But I will answer it in earnest. And if I don't know, I'll tell you I don't know and I'll look it up for you. So essentially what I did this time is I wrote down some frequently asked questions that I get from patients and caregivers to kind of guide the talk. So, one is, what are the most common types of skin cancer? So just like you said, Ms. Sykes, so I know Dr. Patterson. So Dr. Patterson helped train me very fond of him, a great dermatologist. And you were probably going to see him for actinic keratoses and basal cells and squamous cells because they're far more common than melanoma, right? So, so these are the three big ones that we think of, right? We think of basal cell skin cancer, squamous cell, and melanoma. And a lot of times we group them, we used to group them as non-melanoma, and we would call those basal cell and squamous cell and melanoma skin cancers. When we talk about how many skin cancers are diagnosed per year, does anyone have an idea? Throw out a number, right? How many skin cancers do you think is diagnosed every year? Yes, you've seen this talk before, right? Or you've done your homework. Exactly. It's about 5.4 million, right? So well done, well done. I have a pen for you if you like. Yeah. No, I intend to keep that. Yes. So you can see that skin cancers dwarf every other type of cancer. And when you break down skin cancers, you can see that the most common skin cancer that we diagnose in this country is basal cell skin cancer, about 4 million cases a year, about 1.2 million cases of squamous cell carcinoma, and about 200,000 cases of melanoma every year. About half of those are in situ, right? So that means that it's stuck in the paper thin top layer of the skin, and about 100,000 are invasive. It means that it's gone beyond that top layer of the skin. So to give you an idea then, melanoma makes melanoma the 5th most common cancer that we diagnose in this country, right? So basal cell, squamous cell, breast, lung melanoma. All right. So what is melanoma, right? And I know this is an audience that probably knows about all of this, but sometimes I like to kind of break it down into kind of simple terms, because if you can understand where melanoma comes from, maybe we understand kind of why it does what it does. So essentially, this is a melanocyte. So this picture over here is a cartoon of the epidermis, your top layer of the skin, right? So all of these kind of pink cells that are here, these are called keratinocytes, okay? So these cells, when they become cancerous, they become basal cell and squamous cell. A melanocyte is this thing over here. So what a melanocyte does is it makes something called melanin, right? So melanin, it is made in this cell and it's transferred through these arms, these octopus-like arms, into these skin cells, these keratinocytes, but it also keeps some for itself. And what melanin does is it becomes like an umbrella over the cell nucleus, right? That's important because the nucleus is where your DNA lives, right? So if you didn't have an umbrella and sun was shining directly on your cell nucleus, you'd have a lot more mutations, right? So that's the point of having melanin. So if we look at types of melanoma, I think Dr. Myers mentioned this a little bit earlier. So on the skin, there's a number of different types of melanoma that we diagnose. So if you've ever looked at a pathology report, it'll say lentigo melanoma or superficial spreading melanoma or a nodular melanoma. They'll use these types of terms. And it's not just, it used to be kind of descriptive, these terms, but it turns out that there's something to each of them, right? Sometimes there's even different genetic mutations to each type of melanoma, right? So superficial spreading is the far and away the most common type of melanoma that's diagnosed. Then there's something called a nodular melanoma. So nodular means that it makes kind of a bump, right? Whereas a superficial spreading melanoma is oftentimes flat. And then there are these kind of weird sites where people can get melanoma. So people can get melanomas on their nails, right? Or on the heel of their foot, right? So there was a famous reggae singer who had melanoma on his nail. So Bob Marley, so that he had an acral lentiginous melanoma. You can even get melanoma at mucosal sites. You can get it in your private parts. You can get it in your mouth. You can even get it in your eye, right? So, and sometimes I didn't want to get too far into this, but Dr. Googe earlier talked about like melanoma that goes to, that metastasizes, but we never find the primary site, right? So melanoma with an unknown primary. There's lots of theories why that happens, but one of the things that we think also may play a role is you need melanocytes, not just to protect from the sun. So what melanin does, the way that it protects from the rays of the sun is is essentially it mops up these things that are called free radicals, right? So free radicals make little holes in DNA. They cause DNA mutations, right? So melanin soaks that up. So we have melanin in our brain, we have it in our meninges, we have it in our ears, right? To do those types of things. You know, your sun isn't going to shine in your ear, but that's what it's for. You have it in your GI tract as well. Sometimes people will get melanomas in their GI tract. So the question is, why do you have melanin there? That's why. You have it in your eye because did anyone ever make a pinhole camera when they were little? Right? So you have to coat the inside of a pinhole camera with like black construction paper, right? So you can get a clear picture on the back of the camera. That's your eyeball. Your eyeball, your retina is like the back of a camera, and the inside is coated with melanin, right? To allow you to focus. So that's why you have melanocytes and melanin in these other sites. All right. So melanoma risk factors. So, you know, you all know this, but there are some people who have a genetic predisposition, right? So people who have fair skin, particularly redheads, are more prone to this. There are UV associated factors, right? So sun exposure, we know, is important. The other thing is your immune system. We didn't talk very much about it, but people who are immunosuppressed, their risk of melanoma is a little bit higher than people who have an intact immune system. All right, so this is essentially what happens. So your sun, it emits lots of different types of rays. So it emits visible light that we can see. It emits light that we cannot see. So that's ultraviolet light, right? And there's two relevant ones that come into play when we're talking about skin cancer. So it's UVA and UVB. And what these do is they damage the DNA. And when your DNA is damaged, so your cells normally have repair mechanisms. So these repair mechanisms come by and they clean up the damage, and you never know, but sometimes they miss a spot. And if they miss a spot in a keratinocyte in the gene that can cause cancer, you get a basal cell skin cancer or a squamous cell skin cancer. If it happens in a melanocyte, maybe you get a melanoma, right? So that's the idea. So when do I need to see a dermatologist, right? So, you know, this is they talk about the ABCDEs of mole surveillance, right? So when you look at a mole, when somebody comes to see me and I'm doing a skin check and I'm looking at everybody's moles or every mole on someone's body, I'm inside my brain is going through this calculation. So I use my naked eye, but I also use a tool called a dermatoscope, which is like a magnifying glass with polarizable light. So I can see something like this and I can say, well, you know, does it have any of these features that would make me want to biopsy it? So A is asymmetry. So you can see here that if you cut a mole in half, one side should look like the other. It should be like a mirror image. B is border. So you want kind of a nice, you know, even border. But if you start to see kind of scalloped edges like this, that's not normal. C is color. So you can see this mole has a little bit of black, maybe a little bit of like bluish kind of green here, a little bit of red and a little bit of brown. So you want one color, sometimes two colors, but having three or four, that's not normal. D is diameter, right? So if it's bigger than a pencil eraser, which is 6 millimeters or like a quarter of an inch, that's a bit of a warning sign. And E is evolving, it's changing. It used to be the size of a 3 millimeters, let's say, and now it's the size of a quarter, right? That's not normal. The other thing is family history. So anytime somebody comes in, I always ask, you know, do you have a family history of melanoma? And this is what I'm looking for. So I'm looking for, you know, mom to son, son to daughter, daughter to son, first degree relatives, right? Because that implies that maybe there's one of these mutations that Jamie even talked about earlier that may make you more prone to developing melanoma. And then there are risk factors. So one of the risk factors, this picture is intended to show, you know, these are all benign moles, but if somebody comes in and they have greater than 50 moles, that's a risk factor for melanoma, right? We think that 2/3 of melanomas come up brand new, de novo, from scratch. So didn't used to be a mole there, now there's a mole, red flag, right? But 1/3 of melanomas come up from existing moles. right? So it used to be, nice and pink, and now it's got a little bit of, a tail to it, and it's dark, it's gotten bigger. That's about a third of melanomas, right? What you mentioned, Ms. Sykes, is actually really important. So a lot of times we'll diagnose melanomas on patients who are coming in for other things. So they have a history of basal cell or squamous cell carcinoma, and we do a skin check on them and we say, hey, listen, there's a spot here, right? And we have to biopsy that. And that's kind of the behind the scenes of what we do. All right. Does UV protection matter? Right. So I'm not going to get into the weeds too much about this, but there's actually a little bit of controversy about this. And I would argue that yes, absolutely it matters. Intuitively, I just told you that the whole point of a melanocyte is to make this umbrella for your cells, right? To protect you from sun exposure. So if you can get extra sun exposure, why wouldn't it help you? Right. But it's a little more complicated than that. All right, so how do we prove that ultraviolet radiation and protecting you from ultraviolet radiation is important? So a lot of studies come from Australia and New Zealand. So these are countries that have the highest incidence of skin cancer and melanoma in the world, right? So they make Blue Lizard, which is one of the earliest and best sunscreens that existed. So there are studies that show that the closer you get to the equator, it increases your risk of melanoma by a certain percentage by every degree you get closer to the equator, right? What about UV exposure and artificial UV exposure? So everybody knows about tanning beds, right? And tanning beds, we tell you, are bad, right? And the reason why is, so let me back up a little bit. So does anyone still call sunscreen suntan lotion? Does anyone know people who call it suntan lotion? Yeah, so you're not wrong, right? So that's what we used to call it. So I'm going to give you a slide. Let me go forward before I go backward, but let me show you this. This is history of sunscreen. So there was a German chemist who made the first sunscreen that we're aware of. And he was an alpinist, right? So he was a skier. So he would get burned every time he'd go up in the mountains. So he created this cream that gave you about an SPF of 2. In World War II, we would give our soldiers a survival pack, and in the survival pack would be this thing that it was called red veterinary petrolatum, and it was basically Vaseline that was red, and it smelled terrible, and they'd put it on because they thought it would heal the skin and it would protect them from sunburns. So Benjamin Green was a soldier, and he thought, I could probably make a better version of this. So he put a little bit of cocoa butter in it and coconut oil, and he made Coppertone. So that was the first kind of really good sunscreen that was created. Does anyone remember this picture? Yeah. So I always tell this story because I'm from Miami. So I grew up in Miami, and there was a billboard where this dog, it would toggle, and it would kind of be pulling down her shorts, and you'd like drive by it, and it was going towards the beach from the airport, right? The irony is across the street was the University of Miami Department of Dermatology, right? So that billboard was there for many, many years, and in 1990 they changed it to that bottom one, right? So the idea was, for about 30 years, we thought that UVA and UVB, that UVA caused sun tans and it gave you this nice golden color, and UVB caused burns. So UVB was what was causing skin cancer, and UVA was good for you. So that's suntan lotion. It would just protect you against UVB. And what we found is that people who would use suntan lotion, their risk for melanoma was higher than people who didn't use suntan lotion, right? Because they would go to the beach, think that they were protected, and they would get melanoma, but they wouldn't get as many basal cells or squamous cell skin cancer. So that's kind of the idea behind sunscreen. So now we say that sunscreen has to be broad spectrum. So we'll talk about that in a second, but I just wanted to give you a little bit of historical perspective. So tanning beds, they use that idea of, well, UVA is good and UVB is bad. And, you know, your normal ratio of UVA and UVB from sun is different than what you get in a tanning bed. So in a tanning bed, it's a lot more UVA than it is for UVB. So in Iceland, they have a limited population, and they have a very good kind of national health service database. So prior to 1990, Iceland had a lower melanoma rate than other Nordic countries, but it slowly increased over 10 years. And then in 2000, it surpassed the other countries. So when they went back and they looked at this, the sharpest rise was among women who were less than 50. Typically, we used to think that men make melanomas on their trunk when they make it on the skin, and women usually make it on the extremities. But this was flipped. These women were making it where the sun don't shine, right? So they were getting a lot of melanomas in non-sun exposed kind of areas. And what we found was that there was this really sharp rise in tanning bed use. So the health service in Iceland did a very aggressive campaign explaining this relationship. And after they did that, the incidence really declined after that. And other countries have done the same thing. So we've seen similar trends. So what about sunscreen and melanoma, right? So it's hard to do studies where you tell somebody, okay, well, you wear sunscreen, you don't wear sunscreen, and let's see what happens, right? So in Australia from 92 to 96, they had this big study, and they had, you know, more than 1,000 people, and 800 were in one group, 800 were in another group. And for one group, there was a no intervention group. And they said, do what you want, right? If you use sunscreen, use sunscreen. If you're going to go to the beach, go to the beach, do whatever you want. And the other group, they said, no, you have to wear sunscreen, and you have to put it in these spots. And to make sure that you're using it, we want you to give us back these free bottles of sunscreen, and we'll make sure you're consuming it, right? And what they did is they followed them for 4 years where they actually intervened, and then they left them alone, and they followed them for another 10 years after that. And what they found was that in the intervention group, there was 50% less melanoma, right? So half as many melanomas, but more importantly, there's a 75% reduction in invasive melanoma, right? And what was interesting was the melanomas that they made were less aggressive than the melanomas in the non-intervention group, right? So again, these are hard studies to prove and to demonstrate, to undertake, but these are kind of the most compelling ones that we have. All right. So what about what type of sun protection should you use, right? So there's sunscreen, there's hats, there's UV protective clothing. We talked about the history of sunscreen. So what is SPF? SPF is a measure of redness. So it only measures UVB, and it basically tells you it's measuring something called the minimal erythema dose. So what dose and how much time do you need to be outside before your skin starts to get red, right? So if I put something on that's an SPF of 3, it means you can use either 3 times the dose, or you can be out 3 times as long as somebody who doesn't have that, right? So that's kind of the idea. A white undershirt like I wear every day gives you about an SPF of 2, right? Just to give you a frame of reference. My pigment, right? So I'm of Indian descent, so I have, you know, a lot of pigment. This is only about an SPF of 4, right? But it's always on me, right? Just to give you an idea. All right. But let me tell you one other thing about that. So one important aspect about wearing sunscreen is, well, I'll tell you in a second. So there's different types of sunscreen. There's these things that are called physical blockers, and then there's, they call it organic sunscreen, but it's actually the chemicals like oxybenzone and cryolates and, octylcryene, patamate, all of these types of things. So zinc and titanium, those are the types of sunscreen, remember back in the day, that lifeguards would wear, and it would turn your skin white. And then these other ones are, much more elegant. You put them on and they kind of absorb right into your skin. But there's a difference, right, in terms of efficacy a little bit. So the zinc and titanium, the way that they work is they reflect sun, right? So these are always going to be a little bit more effective than these other sunscreens. So these other sunscreens, basically what they do is they take those rays of the sun, they absorb them, and then they emit them as heat, right? So that's kind of the way that it works. Now, when you get a sunscreen, it has to say certain things. it changed about 5 or 6 years ago. So essentially, you have to write that something is broad spectrum and SPF using the same font size. So they're trying to make it so it's not as deceptive. I'll tell you what broad spectrum means in a second. If it's not broad spectrum, it must say the product has only been shown to prevent sunburn, right? We talked about UVB prevents burn. Broad spectrum means that it protects you against UVA as well. It can't say that it's waterproof anymore. It can only be water resistant for 40 or 80 minutes. And there is no, it used to be you could buy sunscreen that was like SPF 90 or 100 or something like that. You can only say greater than 50 now. The reason why is all of these studies, when you wear sunscreen and it says it's an SPF of 30, do you know how much you have to apply to your whole body to get that? Like how much? You're close. It's a shot glass. So it's a shot glass, but every 2 hours if you're going to be outside. Another easy rule of thumb is to use a teaspoon. So a teaspoon per body part. So a teaspoon for your face, a teaspoon for your neck, a teaspoon for your chest, a teaspoon for each arm, a teaspoon for each thigh, a teaspoon for each shin, right? So that's every 2 hours if you're going to be outside. And the recommendations are every 4 hours in general, right? So nobody does that, right? Let me see, I've got a couple more slides here. I have a lot of times I'll give this talk and patients will ask me very good questions. And I thought I would just put them here. So one is, will sunscreens make me at risk for vitamin D deficiency? So the answer is yes. Even I just told you about my built-in sunscreen. So I'm more likely to be vitamin D deficient than somebody who has fairer skin, right? So the solution is you have to go to your primary care doctor and have them measure it and you supplement, right? But that's kind of the idea. Some people ask, well, tell me about nanoparticles. So remember I told you about the zinc and titanium? So those are the sunscreens that I wear when I go outside. And up until recently, when I would do it, my kids would be like horrified because I turn white like a ghost. So I look like I'm, I don't take care of myself and, just a little odd. So now I use a tinted zinc and titanium, right? So it kind of matches my skin tone a little bit. But one solution to this was that they started to make nanoparticles, so really, really tiny particles of zinc and titanium, so it wouldn't leave that kind of white sheen on people. The problem is some people would, they'd be worried about, well, absorption. These are so small that can it get into your skin, get into your bloodstream, et cetera. So the answer is it probably doesn't, right? So our skin, remember I showed you that cartoon of like the many different layers. So it gets trapped in the top layer of the skin, which is where you want sunscreen, right? So it doesn't really go down any deeper than that. But the one thing you should be aware of is inhaled nanoparticles. So if you get an aerosolized zinc or titanium based sunscreen, I wouldn't use that. That's just me personally. And then patients will ask about, the different chemicals in sunscreen. So oxybenzone is one. And some people ask, does it have anti-androgenic effects? It can in studies, in animals, but it's like not physiologically relevant, right? So you'd have to use it for like 277 years, right, to actually get those types of effects. The one thing that oxybenzone does do is it kind of bleaches coral reefs. So these are kind of chemicals when you go to the ocean and they say, oh, be careful what type of sunscreen you use. Those are the ones you want to be careful of, beware of. All right. What about sun protective clothing? So there's SPF, right? And then there's UPF. So UPF measures total UV absorption, right? So this is where you're looking at the ability of a fabric to block rays of the sun. So this is more precise than measuring if something is broad spectrum or what the SPF is. You use a device called a spectrophotometer. You have light here and you put your fabric. Whatever goes through, right, is measured and it's collected. So for example, if something has a UPF of 30, it means that 1 unit went through for every 30. So you blocked about 96.7% of the sun's rays, right? This is more effective than sunscreen, right? There's no question about it because you're wearing it. It's durable. You don't have to worry about reapplying it. And it lasts a little bit longer, right? So these are basically the different scales that you can see. Most likely nowadays, you won't find anything that's got a UPF of less than 25 in a store. When I started giving this talk several years ago, you could only find this clothing in like REI and, like places like that. Now you can go to Target and Walmart and they've all got it. And they're thinner. It used to be, like very, very thick. It was kind of like that episode of Seinfeld where George worked for the Yankees and he wanted them all to wear like, I forgot, was it the polyester or something like that? So it was protecting from the sun, but it wasn't very comfortable. So that was a problem. And these are some very reputable brands that you can see. But as I said, nowadays, they're pretty ubiquitous. You can find them everywhere. This is a picture of Dr. Olilla went to Australia and did a fellowship there for a while. When he came back, I asked him, I said, what happens to the kids, when they go out and they play? And he said something about no hat, no play. And it's true, right? So if they don't wear a hat, things are covered. They're very, very careful about protecting their kids from the sun. Basically, that's all I have. Thank you for your attention. Yes. So it's a good question. So what I say is, if you're coming to see me, right, and you've got a spot of concern, is there anything else you'd like me to look at? And, nobody ever died of being embarrassed, right? So that's what I always say is, yeah, I'll look at everything, whatever you want me to look at. I'll look where the sun don't shine. Yeah. So I'll tell you, like, it's interesting. So, as a male, right, when I examine another male, I'll still ask, I'll say, look, I'm going to look at your backside now. I'm going to look in your groin. Is that okay? For a female, when I examine a female, I ask, I said, is there anything on your breast, under your breast, in your groin area that you'd like me to look at, right? Or you feel comfortable with me looking at? And usually it gets people thinking, like, should I have somebody looking there or not? And then if I see like there's like a little hesitation because of this, right? Then I say, look, if you have a GYN, or we have other female dermatologists here, but you should have somebody look, particularly, if nobody's ever looked before, right? Because it's rare, but you can get, things down below as well. Yes.
I think what Dr. Beck said, if you go to a dermatologist,
Yeah.
they should look from head to toe and every crease. Is that correct or not?
So normally, right? So yeah, I guess, everyone's got a little bit of a different style, but I always look between people's, their nails, their fingers, their toes, the whites of their eyes, inside their mouth, all of those places. But sometimes if you go to see a dermatologist and you say, look, I'm here just for this, right? Then, they may not look everywhere. So I think it's kind of that communication needs to be on both sides, right? Yeah. Yeah.
I have a virtual viewer has a question. I think you kind of touched on it, but she'd like to know if you recommend lotion versus spray sunscreen, and is one more effective than the other?
Yeah. So, the general principle is it's just like moisturizer. So what I tell patients about moisturizer is, you can use a lotion that you can pump out, but it's not as good as a cream that you can scoop out, right? So formulation matters. So creams are more effective as moisturizers than lotions are. Similarly, the spray on sunscreen, yeah, it's better than nothing, but it's not as good as the sunscreen, the creams are. I think you asked, how can you get skin cancers or melanoma in areas where the sun doesn't shine, right? That's right. So I'll answer that in two ways. So one is, non-melanoma skin cancer. So 2 weeks ago, I biopsied a basal cell on a woman's labia, right? So how is it possible that she got a basal cell in that area? You start talking to her and it turns out that she had cervical cancer many, many years ago, and she was treated with radiation in the area. So radiation is a wonderful tool. We talked about it, right? But one of the things that happens is radiation, the longer you go from when you had radiation, your risk of basal cell is actually higher in that area. So that's one reason. The other reason is I've gone back to this slide and I wanted to show you something. So the mutation that Bob Marley had, So he didn't have he wasn't wearing flip-flops. Maybe he was, but it wasn't because of that. That's not why he got melanoma on his toe. It's because he has a different type of mutation. So the mutation that you can get from non-sun exposed melanomas, those are different than melanomas that you get on sun exposed skin, right? So that's kind of the way to think about it. So I have a mole in my eye, right? So that mole in my eye, I have to go see an ophthalmologist every year to make sure it doesn't ever turn into this thing that's over here, right? But it's not because I didn't wear, sunglasses enough of the time. It's in the back of my eye. Yes, yes, probably, or sporadic, right? So, just, bad luck, right?
The sun and in the shade.
Yes.
And secondly, if let's say you're on a boat
Yeah.
and you're in the shade.
You're asking for a friend, right? Yeah. Yes. Yeah. Yeah, it's a good question. So the question is, if you're in the shade or if you're, under some type of a canopy, do you have to worry about sunscreen? The answer is yes, right? So it's for a variety of reasons. So one is, not all canopies and shade are created equal, right? So, that's the whole point of sun protective clothing. So I'll show you a slide. I was trying not to show it because it's a little gratuitous, but this may answer your question. So, this sun protective clothing, right? If you take mice that are susceptible to forming skin tumors, if you don't shine light on this susceptible mouse, they don't make tumors. If you shine light to this susceptible mouse without any protection, they make a tumor. If you shine light to a typical fabric, right? Like a fabric that's normal, nothing special, they will still make tumors. But if you shine light on a mouse that's protected, that has, this sun protective factor, it will be protective to them. So to answer your question, like I was saying, about my undershirt, it gives me an SPF of 2, right? So it's probably letting through about 50%, 40% of the sun's rays. But if I wore that special fabric, I'm protecting myself from 96% of those sun's rays. So you asked about reflection. Absolutely. Reflected sun rays, it may not be as potent as direct sun rays, but it could still cause you to have the same issues. Yeah. Yes.
I have a couple of questions. In biologics cause melanoma versus cause skin more susceptible, whereas it cause the immune system
Yeah. Yes. So the question was, do biologics increase your risk of skin cancer and melanoma? So you mean like biologics like Humira, Enbrel, like these types of things? Yes. So the answer to your question is yes, they can increase your risk of skin cancer by a little, right? So remember we spent the whole day talking about different therapies for melanoma. So I'm going to kind of flip it on its head a little bit. So some of the most effective therapies that we have for melanoma, what they do is they rev up your immune system, right? So it's like having, your foot on the brake and your foot on the gas. So these PD-1 inhibitors, they basically take your foot off of the brake, right? For your immune system to kind of be really, really revved up. So the opposite of that is what if I inhibit your immune system's ability to work? So your immune system doesn't just kill bacteria and viruses, right? So it's active in surveillance. So the answer to your question is yes, but different medicines increase your risk by a different amount. So for example, I see a lot of our solid organ transplant patients. So their risk of making squamous cell carcinoma is 200-fold their risk if they weren't immunosuppressed. But their risk of making melanoma is only 3-fold, right? So it's still higher, but it's not as high as squamous cell carcinoma. So those biologics, they increase your risk of skin cancer in general, basal cell, squamous cell melanoma by 3-fold. So not 200-fold, by threefold, and melanoma is a little bit less than the other ones. It's probably even controversial, right? It's more certain about basal cell and squamous cell. Great question. Yeah. Yes.
Regarding the use of a CPAP, which has plastics in it that may be proven that maybe should be out around the body. And that cause, your studies that show that can cause carcinomas on around the face. I've had two recently surgery.
Right.
Low surgery.
Yeah. In that area. Yeah. Yep. Yes. Yeah. Yeah. No, it's a good question. So the question is, can, wearing something like a CPAP device or external plastic or something like that, does that increase your risk of skin cancer? And the answer is not to my knowledge. Right. So let me look, and then maybe I'll talk to you afterwards, and then I'll tell you what I find. But I think the answer is no.
Next, we have Tim Sullivan's going to come up and share. Yes, you. Yes, yes.
We're gonna skip it.
No such luck.
Hi. When Paul asked me to do this, I said, what am I going to say? She said, just tell your story. It's compelling. I'm not certain about that, but here I am. So in the beginning, okay, January of 17, a blueberry size bolt here. So I didn't even notice it. My wife, who was legitimately Nurse Ratchet, okay, legitimately. It's even written here before you even said it. She said, you got to go look at that. You should have a lump in your neck. Lumps in necks are bad. I remember the argument. It doesn't hurt. Okay. I'm exercising 11 times a week. I feel great. How could it be bad? Mistake. Okay. Just like you. So I finally went in March, at the hounding. She went from a loving wife to Nurse Ratchet, literally in like 3 days. So I went, had an appointment. They gave me a prescription. Thinking it was an abscess or something. Didn't fix it, obviously. I went back. She cut it open. Tried to pull it out. Nope, it's too deep. Okay. And here's what I feel is the clinical error one. Okay. Is they didn't biopsy it. And Nurse Ratchet turned into a mama Ratchet because she was furious. They cut you open. Why didn't they do that? That's the problem. Honey, I'm just a patient. Okay. But because it was 2 months before I actually had biopsy. Okay. The third visit was when the ENT surgeon cut it open, dug around for like 45 minutes. Figured this is too deep. I need an OR, but I'm going to biopsy it. Okay, great. Because I had forgotten the argument. So then we go to Nashville. And the whole time we're there, she said, did you get the results back? Did you get the results back? No. She thinks I'm lying to her because I don't want to ruin the weekend. I'm going to walk around with cancer and not tell you. But so we were watching Dancing with the Stars. The Tuesday we came back, it was a finale, season finale. And I get a my chart message. You've got, basically melanoma stage 3. I'm like, really? So, and then I showed it to her. That much I didn't want to. That's when the crying started. If you're new to this, or you're very early on, crying is normal, it seems. Okay, because there was a ton of it. At traffic lights, dinner, the couch, almost every visit for the first 3 or 4 months. Okay. And the killer was the going to sleep at night, crying herself to sleep. Okay. That's, there's just nothing you can do to fix that. It took months. So, but it was certainly there. Then we go, after the biopsy, we go to see the doctor, and she's not happy at all. And she's got him on a hot seat, professionally, clinically. And she's growing him. She's professional, she's cool, but she's got that look in her face, like she's a attack dog. And I'm sitting, she might love me almost as much as the dog. I'm like, this is cool. But we came here. That was the Thursday before Memorial Day weekend. Tuesday after Memorial Day, she calls UNC. We get in Hillsborough. We see Dr. O'Willa. Okay. So that's the second, I guess. does what he's got to do. I have my first surgery on her birthday, June 5th. Then I have a PET scan, more cancer, surprise, surprise. Okay. Another surgery in June, the middle of June of 2017. We think we're good. We start to do immunotherapy. Okay. And honestly, I got melanoma at really a good point. 5 years earlier, stuff would have been a lot worse than it was. And quite frankly, it wasn't bad at all, overall. The surgeries, like I said, I had 3 total, 2 in 17, 1 in 18. Okay. After the second one is when Dr. Olilla and his team, the whole team said radiation. Okay. And it was a big mistake when I said no. I should at least listen to Dr. Chara. I didn't even give him the courtesy of a meeting. Okay. So we go to Keytruda, right? It's immunotherapy. And it's kind of working or not working. But after 6 months, we realize it comes back on my neck. That's when the third surgery comes in. Okay. And at that point, I actually transitioned to Dr. Colicchio. Things went really well. And I'm going to use the abbreviations for the medicine because they're hard to pronounce and I don't pronounce them often enough. Okay. But my first 4 treatments were IPI and NIPI. Okay. And they tell me that, the two together, the side effects can be terrible. Didn't have a thing. Okay. And then I went through, it was like 13 or 14 months of just IPI. And the only side effect I've gotten from that, is a rash in the back of my calf. And Paul was kind enough to call in some cream that got rid of the itch immediately. And overnight, the rash disappeared. So very fortunate with that. After that, when I got, it came back in my neck. Okay, that's when I had the third surgery in October of 18. Okay, and that's when I did radiation. After that, that's when they finally said, "Listen, you have no choice at this point." So I did it, and I know the doctors up here spoke very eloquently about it. But for those of you who it's on the table, I'll be a little gritty. Okay, my note here says radiation - yuck. Okay, it's not fun. I'm not going to lie to you. Okay, at least the head and neck. Okay, burned your face, burned my neck, took away my taste for 6 or 7 weeks, whatever it was. But it got rid of the cancer. Okay, and I should have done it the summer of 17, the fall of 17. And I don't think it moves to my liver, my lung, kidney, something like that. So after the radiation, we start the IPI and the NIPI stuff, and it works. All right, everything's gone. The one on the liver is getting smaller, the one on the lungs getting smaller, and nothing else is popping up. Good news. Then I go do a race in Kentucky. Okay, I used to do Spartan races, the 5, 10, and 15-mile runs with obstacle courses and stuff like that. As an old guy, I need goals. So I train to a goal. So I do the race. Everything's great. Except I hurt my hip. Oh man. I mean, sometimes it's just an old guy pain. It goes away overnight. Take the motion for a day or two, it goes away. This didn't. So I finally went to the doctor. He does an x-ray, they do an MRI. Okay. Something with my label. When they did the MRI, they had to call Dr. Colicchio because they found cancer in the hip. So Dr. Chera, who's brilliant, says, "I'm struggling to believe this. I want another PET scan." Sure enough, cancer in the hip. So we're doing radiation on the hip now. Okay. And as I mentioned, the collateral damage, okay, it's extensive. Okay. So I had to ask the doctor. It was Dr. Pearlstein that was here. Him and the other resident. I said, about the collateral damage. I said, this is going to be in a pretty sensitive area. Okay. I said, "Are you going to turn my testicles into craisins?" Because that was my concern. I'm not kidding. If you saw my face, you'd have the concern too. And they assured me they wouldn't. So it was only 4 treatments. 6 treatments for the bone. So it went well. And between that and IPI, it's kept it away. I stopped the treatments in June of 20. I've had 3 clean scans. I'll have another one in June. I don't, you know, I never really felt bad, except on radiation, the fatigue and stuff, but I never felt bad. Like I said, the side effects were mild. So Paula mentioned UNC, and I just want to touch briefly on the time of UNC. And I'll apologize for keeping everybody even later, but historically running behind. I think they start their day half a day behind. They really do. But the folks that work here, you know, my first interaction, much like yours with the first doctors, wasn't great. Okay, I haven't had that here. Okay, the people here want to do well, and they strive for it and work hard at it. And UNC doesn't always put them in the best position. Okay, I feel I'm not a very patient person, so sometimes you get me and I'm angry. It's got nothing to do with you. I'm just tired because I've been waiting 2.5 hours for something. Okay, or I had to go to this window, then to this window, then to this window, then to wait. You know, that kind of stuff. But everybody here, I mean, from Tori in the clinic, the scheduler, you know, it's just everybody goes above and beyond. So, and in the interest of shortness, I will end it there. Thank you.
Next, we have Dr. Denise Spector, who is an oncology nurse practitioner with integrative medicine, and she is going to speak about the role of integrative medicine for patients with melanoma, and she does a wonderful job integrating everything and looking at everything and helping our patients. So, all right, thank you.
As was said, I'm an oncology nurse by background. I've been in oncology for almost 33, 34 years. And I was in the area early on in phase 1 clinical trials. Many of you have been on clinical trials. And this was way back when we didn't have some of these amazing drugs that we have today. We were using high dose interleukin, and our patients were getting really sick, and most of them spent much of their time in the ICU as a result of the treatments. So we've come a long way, but there's so much more I think that we can be doing. We're grateful that we have these great drugs, but let's harness the body's own ability to help in the healing process too. I just saw after over 30 some years of being in oncology that there was this missing piece, and that really is that whole health part of it. Of course, we need our treatments, radiation surgery, immunotherapy, chemotherapy, but there's more that we can do, I think, for our patients. And just because of the educator in me, learning objectives, just differentiate between integrative medicine and alternative medicine, because a lot of people hear that term alternative, which is very different than integrative. And then just to describe 3 evidence-informed strategies that may help improve the quality of life for individuals living with melanoma. And then discuss the role of lifestyle approaches for enhancing well-being during and beyond cancer treatments. So, you know, many people kind of look for that miracle cure, and we know it doesn't exist in a supplement. And many people talk about they're not going to get conventional treatment. And, you know, most of the time they don't do so well. So integrative oncology came about, and integrative oncology is more that part of oncology where individuals get conventional chemotherapy, radiation, immunotherapy, but then all of these other modalities that can help in that healing process. And years ago, the term CAM was around. Many of you may have heard it, it's still around. It's the complementary and alternative medicine. And complementary is often seen as these modalities that can be given along with conventional treatment. But again, the alternative is I'm not going for conventional chemotherapy or conventional treatment. I'm just going to go down to Mexico and try this Laetrile or some other unconventional treatment. And then integrative medicine, it's been around for decades, but the Arizona Center for Integrative Medicine, which has been around for quite a few decades, they came out with this definition for integrative medicine, which is a healing-oriented practice that takes into account the whole person, including all aspects of lifestyle, emphasizes the therapeutic relationship between the practitioner and the patient, and makes the use of all appropriate therapies. There's an organization, it's an international organization called the Society for Integrative Oncology. And they in 2017 wanted to come up with a definition that encompassed what they felt was the mission. And integrative oncology is patient-centered, evidence-informed. It's a field of cancer care that utilizes mind and body practices, natural products, and our lifestyle modifications from different traditions alongside those conventional cancer treatments. The aim is to optimize health, quality of life, and clinical outcomes across the cancer care continuum, and to empower people to prevent cancer and to become active participants before, during, and beyond cancer treatments. And there's a lot of parallel. Ellen, the social worker earlier, was talking about palliative medicine. There's a lot of overlap with palliative medicine and integrative oncology, and you'll see when I talk a little bit more about this, where those parallels come in, because a lot of it's about symptom management, trying to help deal with some of the side effects that come about. So some of the reasons that individuals might seek out an integrative medicine consultation, again, to treat side effects from the cancer treatments, just to improve general well-being, prevent recurrence or spread of the cancer, prevent other non-cancers, or other chronic illnesses like heart disease, osteoporosis, often things that we see as a result of some of the treatments that we're giving our patients. And then to increase the body's own ability to fight cancer. Melanoma, as many of you know, is a very immunologic disease. We've talked about immunotherapies all throughout the day today. And it's one of those cancers that there have been probably one of the more prevalent ones where there have been spontaneous remissions that people have. I think one of the physicians was talking about radiation, that the radiation can prime the body to potentially treat, not necessarily treat, but to get rid of another cancer somewhere else in the body that they weren't aware of. So it's a very immunologic disease. And with some of these modalities, we can enhance immune function. I'm not going to say we can cure with it because that's not what it's about. It's helping the body again and healing along with the conventional treatments. There are many different approaches. I'm just going to highlight a few of them today because I could take probably a couple of days talking just about integrative oncology. Is definitely my passion. But acupuncture, energy modalities, which might be like if people have heard of Reiki therapy or healing touch, just kind of changing the energy pattern in the body, because we all are, whether you believe it or not, we all are made up of energy. Expressive arts. We all know that for some people, music therapy can be very valuable with decreasing distress. Things like journaling can be incredibly helpful. Humor can be incredibly helpful as an expressive way to deal with a cancer. And then lifestyle medicine, which is a big part of what I do and talk to patients about. Physical exercise, nutrition, possibly supplements. I won't get into much of that today. And stress management, massage, mind-body, meditative approaches, spirituality, faith. You brought that up earlier. It's a huge part of the healing process for so many individuals. And then yoga is another great modality for helping with so many of the side effects that patients deal with. So I'm just going to move right into just a little bit of evidence around some of these modalities, acupuncture being one. I don't know if anyone out here has ever had acupuncture or has talked to anybody. Acupuncture can be pretty powerful. It's been around for thousands of years, and there's good reason for that. There are so many studies in the oncology world with acupuncture now. It's probably one of the most well-studied modalities in cancer care. And a very large review of many different studies from last year looked at acupuncture and its use for different cancer-related pains, whether that's neuropathy or post-surgical pain, and found that acupuncture can significantly reduce the pain that patients experience. And that could mean reducing the amount of opioids people are using. And that's been a big area, hot area of oncology and trying to reduce the use of opioids for pain management. So we can maybe augment and reducing the need for other pain medications. And acupuncture is incredibly safe in most circumstances. And there's really no side effect. I mean, the needles are so fine. Individuals might feel just a tiny little pinprick as the needles are going in, but most people tolerate it incredibly well. And then among a number of different cancer survivors, including those with melanoma, acupuncture has also been found to be very valuable for sleep, for fatigue, and almost every cancer patient at some point experiences fatigue. I think you can all, those who've gone through it can attest to that. It's the number one side effect from our cancer-related treatments. Acupuncture can help anxiety, depression, and just general overall quality of life. And some other interesting findings, but also we refer a lot for nausea and vomiting. Thankfully, nausea and vomiting isn't as, God bless you, isn't as big an issue these days, but for some people who continue to have queasiness and vomiting with their chemo, acupuncture can be incredibly valuable. And another interesting finding is that acupuncture has been found to increase white blood cell count. I have down on the very bottom, leukopenia, that's when the white blood cell counts drop from certain treatments. And in some studies, acupuncture is shown to help elevate the white count and helping with recovery. Switching gears, I'm going to look at mind-body therapies. One of the main modalities is something called mindfulness-based stress reduction. It's a formalized, like 8-week program that individuals go through in their training to become proficient at working through meditation in this particular fashion. And this very large, in 2019, this very large, what's called meta-analysis, which was of 14 individual studies. And for a meta-analysis, what they do is a specialized statistical program or statistical analysis that combines the results of all the studies to help strengthen the power of the results, to give better understanding about the benefits that potentially could derive from these treatments. And this big analysis showed that MBSR, which we call it for short, mindfulness-based stress reduction, decreased anxiety, decreased depression, decreased fatigue, and it actually improved cognitive function. A lot of our patients get that cognitive dysfunction from either radiation to the brain or from general chemotherapy, and sometimes even from hormone therapies, from immunotherapies. Even some people have had some cognitive issues. And then just, you can see some other studies here, 2017 review. This one was actually pretty interesting too, because it looked at biomarkers of inflammation, that this MBSR can actually improve some of the biomarkers that we see that stress can cause on the body, or that cancer can cause on the body. So it can actually enhance our immune function. And then the last study, it was another very interesting one. We talked about DNA earlier. At the ends of our DNA are called telomeres, and they're actually these markers of aging. As we age, our telomeres start to shorten. And this study, it was actually looking at those telomeres and found that this meditation, or this formal MBSR, can actually increase the development of something called telomerase, which actually helps enhance the lengthening of the telomeres. It's early evidence, but it's fascinating. So there's something much more to meditation, which has also been around for hundreds, thousands of years in many cases. So again, there's so much more that we don't know about the value of some of these modalities. And looking at another large review, this was another systematic review, meta-analysis, that focused on fear of recurrence. I would say upward to maybe 50%, if not higher. Individuals with most cancers who've gotten through it, might be in NED, no evidence of disease, still deal with that fear of cancer coming back, right? This is a really significant factor in quality of life. And it's really a hard one to work through. So we look at other ways to help individuals in dealing with the stress of that fear of recurrence. And this mindfulness-based stress reduction as well as other meditation modalities have found that they can actually reduce that sense of fear of recurrence and help people live a little bit more easily, a little more with ease, and not constantly feeling that sense of threat. And this was when I was trying to find studies that specifically looked at individuals who had melanoma. And this was an interesting pilot study, a small study. There were about 70 patients that were randomized, meaning they were either put in the intervention group of this online mindfulness-based program or in just usual care. And they actually found from this study that individuals who received the intervention had a significant reduction in that fear of recurrence. So again, can't underestimate some of these additional types of strategies to help people live better lives. As far as modifiable risk factors and melanoma, I'm not going to say there's a lot of evidence out there when it comes to exercise or when it comes to nutrition, specifically for melanoma. And I think it's because most of the studies have been done in breast cancer. It's just because that's where we have the higher numbers of individuals, 1 in 8 women getting breast cancer. They're the ones who go into most of these trials. So again, that's where we get most of the data. But the data is showing that exercise can make a difference. Exercise can stimulate our immune system. There are a host of things that exercise can do. And it appears that nutrition as well, more of what we term a Mediterranean style or anti-inflammatory type of diet. Some studies, large cohort studies or observational studies, are showing that, especially for women with breast cancer, again, going back to that, because that's where the numbers are for the studies, that they have better outcomes if they adhere to a diet that's more along the lines of a Mediterranean style as opposed to our typical Western style diet. And food really is medicine. And it's not something that's emphasized often in oncology. And I think most clinicians, when they're training, didn't even get any education in nutrition. I mean, that's where we get all of our antioxidants. That's where we start to help repair the DNA damage. So I'm not going to belabor the point because of our time, but I did just want to mention there was an early study from 2008 looking specifically at melanoma risk, not for people who already had it, but one can extrapolate, right, and risk reduction based on this, that Mediterranean style diet seemed to have made a difference in reducing risk. Obviously, we need more studies, but I think this is definitely food for thought. And there was a large review study looking at cancer in the Mediterranean diet, and it's actually advocated by the American Cancer Society now. I don't know if any of you are aware, American Cancer Society does have guidelines for cancer risk reduction as well as for cancer survivors, looking at trying to have a variety of fruits and vegetables. I think you probably have all have heard this. I'm not going to go through it step by step, but abundance of vegetables, whole grains, rich legumes, trying to limit or avoid red meats, processed foods, processed sugars, any processed foods really. So these guidelines have been out for a number of years, and there are other cancer organizations that also advocate for this type of diet. And they do mention too, to avoid supplements for cancer prevention, because we don't have any supplements that are going to prevent or cure cancer, right? And patients ask that a lot. And a little bit about the movement therapy. There was one large, very large review study of 66 exercise studies in cancer care, with the majority showing significant improvements in cardiorespiratory function, body strength, body weight, fatigue, functional quality of life, anxiety, mood, self-esteem, and on pain and lymphedema. We heard earlier about lymphedema, not the case where you saw the individual's leg that was quite large. I mean, would be earlier on that certain types of exercise can help with dealing with lymphedema. And resistance training, this goes for aerobic as well as resistance training. The second half of this is looking at a review of 15 different studies showing incredible improvements actually in muscular strength and endurance. On fatigue, going back to fatigue being the number one factor, it sounds counterintuitive to recommend exercise for fatigue, but it is actually the number one strategy that we have for helping to mitigate that side effect. To whatever a person can do, right? Starting where you're at. It's not like you have to jump in and do 150 minutes a week, but 150 minutes of aerobic activity, moderate aerobic activity per week is the American Cancer Society guideline for individuals who've gone through a cancer experience. So it's working up to that as one can. And then I just want to mention yoga, because that's another modality that we have mounting evidence on the benefits of yoga for individuals having gone through an experience with cancer. There's so many benefits. Much of it is on the whole mind-body piece and reducing anxiety, that feeling of stress, helping fatigue, and helping nausea even, as well as pain, and the enhancement of immune function from yoga. And yoga, as many of you know, it's a traditional, Eastern traditional type of, it's not just an exercise, it's whole mind body, but it's a series of postures as well as meditation, as well as deep breathing for relaxation. And we have yoga available at UNC. We have exercise programs available at UNC. We have mindfulness-based programs at UNC. So we have a lot of that available. Bless you. I'm just gonna quickly say something about supplements. As I said, the American Cancer Society and other national organizations don't support the use of dietary supplements, with the exception of cases like low vitamin D, low B vitamins, low B12, things like that. We would definitely want to supplement. And the big thing with herbs and supplements, because I have people coming in with bags of supplements that they're taking, and they don't realize sometimes that there could be drug herb interactions, especially with these immunotherapies. We don't know a lot about what's going on with those immunotherapies and some herbal supplements. So that has to be carefully examined to make sure there aren't any known interactions. And in many cases, during active treatment, most clinicians are going to say, please avoid even taking them. We have databases that we can look at, and the PharmDs, the pharmacists, are really wonderful at the Cancer Center for helping with that too. If individuals are on supplements, just make sure you're letting your care providers know so they can make sure they're looking up to see if it's safe to be given with any treatments that you might be taking. In some cases, we might prescribe or recommend, it's not prescribed because it's available out there on the shelves and pharmacies, but melatonin for sleep. And another one I put up here is called American ginseng. It's a pretty well-known herb, but it can actually help with fatigue. So I recommend that for patients sometimes if they're not on other treatments that might interfere with the actions of the treatment. And just very quickly, I'm just going to mention the role of vitamin D in melanoma. This is early data. We don't know a whole lot about it, but there's evidence indicating that higher blood levels of vitamin D are associated with better outcomes in patients who have melanoma. So it suggests, which was suggested earlier anyway, if you have that, levels should be checked. If they've not been checked, you should at least have a baseline check. And if they're low, they should be corrected. And we have some guidance around that of how much one should have, and it should be in this sweet spot. We don't want it too high, because anything too high can be detrimental as well. We need more studies to look at that, because we really don't know what the role of vitamin D is, but it's just as in melanoma, we're finding that association with breast cancer and a lot of other cancers as well. And for those who might be interested, we have consultations that are available at the Cancer Center right now. They're via telehealth, have been through the pandemic. And it is a medical visit, so it is covered by most medical insurers. Typically, the visits are an hour, and I do follow-up visits for individuals too, if they're interested in that. And it really is tailored to the individual. I mean, just based on a comprehensive assessment of what's going on with them, tailor it to their particular needs and to their particular treatments as well. And I was just going to go over just very, very quickly, because I think case studies are very helpful. And this too is a fictitious case study of LD, a 48-year-old woman diagnosed with stage 3 melanoma. She underwent a wide surgical resection of her lesion, followed by adjuvant treatment with combined immunotherapy. And just a little bit about her other medical history. It included, even prior to her cancer diagnosis, anxiety, depression. She had high blood pressure and high cholesterol as well. She was married, working full-time in a very stressful job, and had additional family stress going on now, as well as that significant fear of recurrence. When she came to me, she presented with several symptoms, including that distress of fear of recurrence. She had fatigue, insomnia, weight gain, depression, cognitive changes. And she wanted to see what could be done to help improve her overall health and wellness, as well as help with some of the symptom management from her prior treatments. And just in brief, the recommendations based on our conversation, we talked about this anti-inflammatory or Mediterranean style diet and the addition of ground flaxseed. That's for the additional fiber. And I'm just going to put this out there. It's very early data also, but Memorial Sloan Kettering and MD Anderson, two well-known cancer centers that have been looking at the microbiome. I think many people have started to hear about the microbiome and the role of the microbiome in cancer. The microbiome is kind of a fascinating field. We don't know a lot about it yet, but MD Anderson and Sloan Kettering are looking at actually melanoma, individuals who've had melanoma and the microbiome. And they actually found that those who had healthier microbiota in their gut, these healthy bacteria, had a higher fiber diet. They seem to do better with these PD-1, these immunotherapies. So it's just kind of an interesting relationship going on there. Makes sense to me, but some people say diet, that's nothing. They underestimate the value of diet. But that's why I often recommend to individuals flaxseed is a great source of omega-3 fatty acids for one, as well as for fiber. And I recommend it because she didn't have a vitamin D level done, to get the vitamin D level. And then if it was low, we would supplement as appropriate. And she wasn't exercising at all. So got her involved in our regular, in our local Get Real and Heal exercise program that some of you may have heard of here at UNC. It's a free program, 16-week. It's a fabulous, fabulous program that's available to our patients. And that's aerobic as well as strength building exercise. And recommended the yoga as well, because she was very open-minded to it. Obviously, an individual has to be open to it. And she was, but that was also important because of her mood, her sleep disruption, that it could help with those things as well. And acupuncture, because her insomnia was so significant. I didn't think that yoga alone would be necessarily as helpful, but acupuncture in addition, which she was also open to. And she was also getting counseling through our comprehensive cancer support program. So continued that for depression. And then just some other things that we talked about, the mindfulness-based stress reduction because of her significant fear of the recurrence that was really interfering with so much of her life and her everyday life, with her job, with her family. And spiritual health. She was very faith-oriented, spiritually oriented. And we just talked about something as simple as a gratitude journal. Anybody who's done that, it can be a really powerful way of helping to remind oneself of the good things, despite the challenges that everyone has to go through and going through a cancer experience, that there really are those joys in life and the good things in life too, that we can go and look back at when we have bad days, right? A gratitude journal can be incredibly helpful for that. And I'm going to end there because 5 o'clock, and thank you all for hanging in there to hear the end of the presentation today. So thank you all.
All right, thank you everybody for staying to the end and being such wonderful participants. I believe you were handed an evaluation sheet. If you could fill that out, that would be appreciated. And again, thank you for making our, I think I speak for Trish and the whole team here, for making our lives much richer and beautiful. So thank you.